blood volume in the circuit that may be lost is about 125 mLs. Still uses albumin and fresh frozen plasma. It is faster, it is smaller, and it can be adapted for cascade filtration. Cascade filtration is where I said you remove the blood comes from the patient into the filter, the initial filter, and plasma is filtered out, the red blood cells go in. This plasma that has been filtered goes into another filter, and you remove the substances that you want to get rid of, and then the plasma goes back into the patient. And it's a better way, I think it's more gentler for the patient. So this is just a pictorial presentation of what I had talked about. So the first one was centrifugal. You can see it's going into the centrifuge, and then this is typically how we do hemodialysis, but now you remove the plasma. So I had talked about this double plasma filtration, and now onto the prescription. So we've talked about the modality, either centrifugal or membranous, and you have to calculate the volume. So a rule of thumb is that for every patient, you estimate that 35 to 40 ml per kg of body weight in a person who has normal hematocrit will give you the plasma volume. And you can also use the Kaplan's equation. And we know that the volume, we use the first order kinetics to estimate how much of the product can be removed during plasmapheresis. So the different replacement fluids, as I had mentioned, can be the patient's own plasma, donor plasma. You can use colloids, which is what we typically use, 5% albumin, which is isooncotic, and crystalloids. So these are just some characteristics of albumin. Albumin is easy to use, easy to store, easy to prescribe. There are very few allergic reactions, but it is expensive and has no coagulation factors. So when you use albumin, your patient is more likely to bleed. Fresh frozen plasma replaces all your plasma constituents. However, there's a higher risk of getting infections through it, and it must be type specific according to the ABO compatibility. It needs to be ordered in advance, and there's a higher risk of allergic reactions and a citrate load. So as I had mentioned, the venous accesses are a wide range. So if you're doing centrifugal, you use the antecubital veins, but if you're using membrane plasmapheresis, you use a temporary access. And if your patient requires plasmapheresis for a long period of time, you can use either an AV fistula, AV graft, or a tunneled access. So how do you decide the schedule for the patient? So it depends on what is your desired outcome. Do you want clinical improvement? I think we won't want clinical improvement, or whether you're looking at reduction in the pathogenic entity. So using that, you plan your schedule. Normally it's on alternate days so that you can allow some time for redistribution of the substance. And you normally target 3 to 5 procedures, but we know that for certain entities there's been studies and that show that up to 7 to 14 treatments might be needed for certain patients. However, for patients who have ITP, we plan for daily apheresis. So before you do the plasmapheresis, you need to know the patient's blood group, the calcium. If it's low, you need to replace it because they're most likely to get hypocalcemia thereafter. Magnesium, potassium, because it might be affected by the citrate anticoagulation, and you know they get hypokalemia. The blood cell count and the coagulation screen. So there are several complications that you need to look out for. So it depends on the patient's condition, the number of procedures you're going to use, the type of replacement fluid, and yeah. So if you're using non-plasma replacement fluids like albumin, you're likely to get hypotension, hypokalemia, and a reduction in the coagulation factors. However, if you're using donor or plasma RBCs, you're likely to get hemolytic transfusions, anaphylactic reactions, transfusion-related acute lung injury, or some viral infections. I had also talked about this complication by the citrate causing hypocalcemia, and that's a very important thing we look out for. You can also get citrate-induced metabolic alkalosis. You might remove or reduce the medications that the patient requires. You may get vascular access complications, and so on and so forth. So just for patients who have hypocalcemia, remember CATS: convulsions, arrhythmias, tetany, spasms and stridor, it's relatively easy to manage. For patients who already have low calcium, you can start an IV infusion of 10 mLs of 10% calcium gluconate per every liter of the non-plasma fluid. So I had already mentioned this. I don't know why it's happening again. Okay. For people who are for patients whom you need to use plasma, you may get anaphylactic reactions. Am I going forward or backwards? Okay. If your patient is on medication and they have other comorbidities, practical way to go about this is just to give once daily medications. Avoid IV medications before initiation of TPE. And if you're going to give oral medications, do not give them within 4 hours. It should be before 4 hours or after the TPE. And for patients who are on chimeric antibodies, monoclonal antibodies, and IVIG, they're normally removed by plasmapheresis, so you should give it at the end afterwards. So if your patient unfortunately requires dialysis and plasmapheresis, do the plasmapheresis followed by the dialysis. Yeah. So having said that, I know I've talked about so many things, but every time you want to do plasmapheresis, you ask yourself these questions. Is this treatment useful for the patient? What would be the correct dose? What is the most appropriate replacement solution? Which filter should I use? And is there a simpler and safer therapy that works just as well? So I just wanted to highlight that we have IVIG, which we use for many of the conditions for which we also use plasmapheresis, and that there's a very big cost difference. IVIG is not available all over the country. It's not easy to access, but your dialysis machines are all over the country. We just need to make the filters more accessible, and the price range is almost 2.5 times the price of plasmapheresis. So plasmapheresis is a relatively safe procedure, can be done by many doctors. The 5 main indications that you should not forget about are TTP, Guillain-Barré, CRDP, myasthenia, and Waldenstrom's. But always remember to give the right therapy for the right patient at the right time. Okay, thank you.
Thank you very much, Joyce, for the presentation that you've just made. I want to welcome you again to the next presentation in this segment of nephrology. So I want to invite our next speaker. Our next speaker is Dr. Matthew Koech. He'll take us through preparing for kidney transplant, the role of physician. Dr. Koech is a nephrologist and lecturer at Moi University School of Medicine. And he's also a consultant that consults for many hospitals around here in Eldoret, including Moi Teaching and Referral Hospital, which is the main teaching hospital for Moi University. He undertook his training at Nairobi University for undergraduate. Later on came to do his internal medicine training at Moi University. And in the year 2013, he went to Stellenbosch University in Cape Town, where he was training to be a nephrologist at Tygerberg Hospital. He came back and is currently also practicing at Oak Tree Center for Kidney and Chronic Diseases, where he pioneered actually the transplant program in conjunction with the St. Luke's Orthopedics and Trauma Center. He has passion in teaching, so he's involved in teaching a lot in this region and across the country, undergraduate, postgraduate, and also fellows rotating through this area of nephrology training. He's also an avid golfer. Those are his other interests, and he likes athletics. So you may, yeah, he runs quite a bit. So welcome, Matthew. I don't have to introduce you more than that. I think.
Thank you very much, Peter, for the kind introduction. Yeah, I normally brag to everyone that the people of Eldoret, if you see us, we look like we run a lot, and we actually do. In fact, we were discussing with Peter this morning when we were on the 7th kilometer of our run about the conference. Yeah, so it's very nice being in Eldoret. I also play golf. I'm captain of the Eldoret Club at the moment, but I'm retiring in a month. And tomorrow, we're actually hosting a doctors golf tournament. So for those doctors who play golf, you're welcome to play tomorrow, the Eldoret Doctors Golf Tournament. Anyway, let's get back to business. I think Joyce has really made a very good case and set the stage for what I'm about to say. That in the last, I think since 2015, there's been tremendous improvement in the service of nephrology in the country. There's dialysis in every county now. There should be at least 5 machines in every county. Some counties have more. And that's really a big improvement. When I started working in the renal unit in MTRH in 08, we had 2 machines, and I think those were the only machines available. And then I think there was maybe 1 or 2 machines in Nakuru, and the next place was Nairobi. But now patients don't have to go far. And it's because of this that things have actually changed. Almost every dialysis unit in the country is full of patients. And the next thing that you guys will start encountering is, Doc, do you think I should get a kidney transplant? How can you help me? And we want to help you guys so that you don't have to struggle and send these patients when there are certain basic things that probably as a physician you can help us with before referring that patient for transplant assessment. And that's what we're going to discuss about. So I've been already introduced. I don't think I need to do that again. And we'll talk briefly about CKD and dialysis and transplant, and then go through the process of preparing a patient. We'll really make it a bit brief. So let's assume you have a 62-year-old man who is diabetic for the last 17 years, has been on dialysis for the last 7 months, and in the process received 2 pints of blood. Comes to you now and says, Doc, I've been told there's an option for kidney transplantation, and my brother is willing to give me a kidney. What do you think? So keep that in mind, and we will come back to that case probably at the end. So as most of you know, CKD is really the presence of kidney damage that has lasted for at least 3 months. And the kidney damage can be in various forms. And there, albuminuria, urine abnormalities, histological changes. So any patient who really has any of that for more than 3 months is a CKD patient. And this includes patients who have already received a kidney transplant. Okay? And then in some cases also, patients like those patients who have Bartter syndrome or Gittelman syndrome, those are patients who qualify. And even the polycystic kidney disease patients, even when they have normal creatinine, they are CKD patients. So pay attention more to the markers of kidney damage, because sometimes the GFR might be normal. And then when it comes to GFR, we are more used to these categories, the G1, G2, G3A, 3B, 4 and 5. Most of you know about that. But we are now emphasizing more on the addition of albuminuria as that additional high definition criteria that will really help you risk stratify your patient even better. So in short, the higher the amount of albumin they are passing in urine, the higher their risk of progression, and the higher the risk of death. And those are the various categories. So less than 30 milligrams in a 24-hour period is A1, which is basically low risk. And then 30 to 300 is the moderate risk. And the very high risk patient is one who has albuminuria of more than 300 milligrams in a 24-hour period. And this is really important. So don't just look at the creatinine, also look at the albuminuria. And this gives us this heat map such that a patient who has heavy albuminuria, despite the GFR, this is a patient who is really at high risk. As most of you know, albuminuria really is a marker of vascular damage and vascular risk. So about 10% of the population will have CKD. And the older you get, the higher the proportions. 10% really is a worldwide marker, but we think that in Africa the number is probably closer to 15 to 20% because of our circumstances, and especially in West Africa where we have very high rates of this genotype called the APOL1. It's very, very high in Africa. We are lucky a bit in East Africa. Studies have been done in Bungoma and in Ethiopia, and it seems like we have a very low risk of APOL1 gene mutation. And that explains why we don't see a lot of CKD probably compared to West Africa and African Americans in the US, and also explains why we don't see a lot of the HIV, the classical HIV-associated nephropathy in East Africa as compared to the rest of the world. Now, when you have CKD, you are living like an elder. So a 25-year-old who is in CKD is living like the mortality risk is similar to someone who does not have kidney disease at an age of about 70. So having CKD puts you in a state where you have accelerated aging. And most of this aging is due to the cardiovascular issues. So dialysis patients really, their mortality risk is way, way, way higher compared to their peers. So what options do we have at the moment? We have dialysis, and really this has been shown to be better than conservative management, especially with PD. The survival is much, much better. And transplantation is the other thing that we have. Compared to patients who remain on dialysis, the mortality of patients who get a kidney transplant is significantly reduced. So transplant is the way to go. But transplant comes with its own risks. The first 90 days after a kidney transplant, the first 3 months after a kidney transplant are the most risky. And as you can see that from the day you get your kidney transplant until about 3 months, the patients actually die way, way faster than patients who remain on dialysis. And we'll talk about that. And it has to do with the accumulated cardiovascular risk and the fact that you're taking them through theater, and that really accelerates cardiovascular risk. But if you are able to go through that 3 months period, then they start equalizing, and after about 6 months, the gains can be tangible. That's when they start beating their colleagues who remained on dialysis. And that period is really important, and that's why we do extensive evaluation of anyone who is deemed fit for transplant. It's because of this increased risk early on. You don't want to put someone through a transplant only for them to die 2 weeks after the transplant. And as you can see, the younger you are, the better for you as compared to the older patient. But I'm not saying that we should not transplant older patients. The bigger benefit, of course, is to the younger patient. But even up to the age of 60 to 74, these guys can enjoy an additional 10 years of life as compared to 6 years when they don't receive a transplant. So that's something you need to consider for your elderly patient. An extra 10 years versus just about 6 years on dialysis. Is it worthwhile? That's a discussion you can have. And if you're able to do preemptive transplants, that means you transplant them before dialysis. So let's say a patient comes to you today, creatinine is 500. You can see that in the next 3-6 months, these guys are going to be on dialysis. And they work hard. In the next 3 months, they get a transplant before they need dialysis. That would be the ideal. So compared to patients who remain on dialysis, their survival is also better. And especially those who stay longer before getting their transplant. Even when they get a transplant, their survival is significantly reduced. So if you're able to encourage your patients to get the transplant early on, mapema ni best. Now, KDIGO has come up with guidelines that really advise us on how to go through this process. And I'll just highlight some of the issues that they deal with. One of the things they say is that really all patients who are in CKD stage 4 to 5 must be informed and educated about and considered for a kidney transplant, regardless of their socioeconomic status, their sex, their gender, race, or ethnicity. And this is a grade 1 recommendation, although it's a grade 1D, meaning it's backed up by low level of evidence. And usually you will need a multidisciplinary team, which includes at minimum a transplant physician, a transplant surgeon, and other professionals, including psychosocial workers or psychosocial counselors, to participate in this evaluation and decision about the suitability of a patient. So always consider every patient and consider referring them to a center that has this kind of team. So when it comes to preparing these patients for transplant, one of the things we ask ourselves, and we have a discussion with the patient, is kidney transplant really the best treatment for the patient? For some patients, remaining on dialysis might be the best treatment for them. And for some patients, transplant is the best treatment for them. And that is something that needs to be discussed and, and dealt with by the doctor and the patient. You also have to consider the comorbidities the patient have, because these things can affect the safety and futility of the transplant, which is really what we want to look at. Are we going to put the patient through a lot of danger for nothing? And think about also, you might sometimes fix the kidney. Patient has a normally working kidney, but then they have other issues like a severely malfunctioning heart or a malignancy. Then the futility there is something of concern. So some of the contraindications, therefore, really the absolute contraindication for a transplant is if a patient has ongoing active sepsis at the moment, or a patient has an uncontrolled malignancy. Okay? Now let's be careful. A patient who has a history of cancer is not excluded from transplant. Okay? But if it's currently uncontrolled, yes, then they cannot go through a transplant. There are malignancies where we can actually transplant patients upfront. There are malignancies that warrant that we wait for a 5-year period, and there are malignancies that we can never transplant someone for. And then, of course, uncontrolled psychosis, active drug dependence, and any medical condition that puts them at a severely shortened life expectancy. And then there's what we call a positive T-cell CDC cross-match, which means that patients who are really sensitized and they have antibodies against their donors, those are patients, of course, you cannot transplant with that donor. But if they can get a donor where they have a negative cross-match, then they can be considered. Previously, we used not to transplant hepatitis B patients, hepatitis C patients, HIV patients, patients who are obese, and so many patients, including patients above the age of 60. But now we are much wiser. I think things have changed. What we know has improved. And right now, I think most centers are transplanting quite a number of HIV patients. We have transplanted hepatitis B patients. We've transplanted patients over 60. And I think what we are still a bit cautious about in this country is the previous malignancies. We're still a bit cautious about that. And I don't think there's any center yet who have done an ABO incompatible transplant. We are yet to get there. So how do you go about preparing your recipient? You have to consider many things. The age of the patient, although age does not really on its own exclude the patient. You look at the underlying disease. So is it diabetes? Is it a GN? Is it, try and identify that disease, underlying disease. That doesn't mean that a certain underlying disease disqualifies someone from a transplant. No. It's just for information, and it helps in risk stratifying the patient and in putting up strategies to prevent a recurrence in future. You look at the comorbidities, and for us, really the most important thing is heart disease or cardiovascular health and malignancies. And then the other thing you really, really need to consider is compliance of the patient. A patient who is not compliant already to treatment, to dialysis, those are patients you need to be very, very careful about, because you might transplant them, and then after the kidney transplant, they are still uncompliant on their medications, and that's really not worth the effort. So those are the patients to really, really be careful about. Those are probably, we are seeing this in our transplant program, that really one of the things we need to pay attention to is compliance. Compliance is a big issue. And then mental state, I think that's fairly obvious for us. So there's this question we always encourage you to ask yourself. Ask yourself, this patient, if this patient was to stay on dialysis, will he be alive in the next 5 years, 10 years? Ask yourself. If the question is no, and it's less than 2 years, probably that's not a patient you should consider for transplant. And then you do the cardiac workup and you do the malignancy workup. So for the cardiac workup, of course, basics, you take a nice history, you examine your patient, but usually at the end of the day, you'll need an ECG, which is very useful in detecting abnormalities, has a good sensitivity and specificity for coronary artery disease. Probably you don't get a lot by doing an exercise ECG, so a basic ECG would be enough. And then you do an echo, which has the advantage of showing you the chamber sizes, the systolic and diastolic function, and the valve diseases that are present. And usually if you can do a stress echo, it's probably as good as a coronary angiogram, and we really recommend that you consider that. And the beauty with an echo is that it's cheap, there's no radiation, but it might have some limitations in patients who have especially things like obesity. When it comes to imaging, we have a host of extra imaging you can do. You have the coronary arterial calcium score, and you have the coronary CT angiogram, which really has a high sensitivity. But both of these techniques are limited by the fact that some patients already have calcification in the medial artery, the medial layer of the artery, and that can really affect things. But if you can do, like I think most centers now can do coronary CT angiograms, it's very important in ruling out. So a negative coronary CT angiogram really probably clears your patient for transplant. Most times though, we end up, especially with diabetics, that we need to do the traditional CT angiogram, which needs contrast. It's the gold standard, has the problem of significant radiation. So we generally just reserve it for patients who have a high risk or are really suspected for severe coronary artery disease, or who have inconclusive workup so far. Problem though is this kind of screening is not really based on strong evidence, and we question whether it really improves outcomes and whether the harms that are associated with some of these tests justify the end of it. We've seen patients who go for CT contrasted studies, and then before dialysis, and their potassiums go up, or they get severe side effects from it, and that's something that can be of concern at times. So really, at the end of the day, this is the protocol that we reserve and probably propose that people use, that you look at your recipient. If they're high risk, then you see whether they're symptomatic. If they're symptomatic, go straight to a coronary angiogram. If they are low risk or they're asymptomatic, low risk, you go straight to a transplant. If they're asymptomatic, you stress them. And if the stress is negative, go ahead with the transplant. If the stress is positive, go with a coronary angiogram and move on from there, where they might get medical treatment or surgical treatment. Now, who are these high-risk patients? The diabetics, males who are over 45, females over 55, a patient who has a previous ischemic heart disease, and a patient who has an abnormal ECG, smokers, and patients who've been on dialysis for long. Those are patients that you should consider as high risk. So any of those one or two risk factors, two or more is high risk, and one risk factor is probably moderate risk. And anyone who does not fit in any of those criteria would be a low risk patient for you. And this has been shown to really work. So patients who have stenosis tend to do really poorly. So it's really important to pick out these patients. In terms of survival, same thing. Patients who have significant stenosis don't do so well. So it's really important to find out these patients and to intervene before the transplant. For malignancies, for the males, we assess for lung malignancies, and that's done by a basic chest X-ray. And that's really mostly enough for most patients, unless something comes up. And for GI malignancies, a colonoscopy would usually suffice, and ultrasound of the abdomen is what we do. And for prostate, of course, the scans and the PSA. And for the hematological malignancies, for us, really, we worry about multiple myeloma. So we normally screen them for multiple myeloma. For the females, there is the addition of breast workup, either a mammogram or an ultrasound, and then the pap smear for those who have not undergone hysterectomy. For compliance, really, it has to do with the social circumstances of the patient. You have to really involve a social worker and a counselor to look into that aspect. And this is probably one of the biggest issues we are facing currently. Patients really need to be assessed for their social circumstances. And you know I'm the chairman, huh? Yeah, it's for their social circumstances and, and their mental state. So involve a psychiatrist, involve your social workers, and do a lot of counseling, because that's really important for these patients. For the donors, really, the younger the better. And really, you're looking for someone who is healthy, but very, very important, especially we're seeing quite a bit of this coming up. It's very important that it be someone who is doing it willingly, because now we're seeing people who come and they want to sell their kidneys. That's a no, okay? Not just legally, but also when you look at it from a medical point of view. Someone who is selling their kidneys, of course, they'll not be related to the donor, so chances of rejection are higher. But also, they put themselves at high risk. Usually, their circumstances already have put them at high risk. And the quality of kidney, you might not be really assured, because these are guys who will be withholding a lot of information from you and the patient. So it's important, really, that we look into this. It has to be someone who is willing and not under duress, including financial duress. Okay, so ideal donor should be healthy. It should not be younger than 18 because of legal purposes, and should not be coerced, and there should be no illegal financial exchange and no psychiatric conditions. So we normally do some basic tests. We do infectious workup, we do a wellness workup, and then malignancy workup, and then we do a matching. And really the aim is to avoid rejection, which can be in various forms as above. And we look at the blood group, and we try, and it's similar to a blood donation. You look at it similarly to a blood donation. And RESAS really is not that important for us in transplantation, unless you're dealing with a young girl who is yet to have children. Then RESAS becomes important. And for HLA, there are various HLA antigens that we look at, but really at the end of the day, it's the HLA-DR, the HLA-B, and the HLA-A, which are very important to us, and those are the ones we look closely. And then at the end of the day, we want to see whether they have antibodies to the donor, and we do a cross-match, which looks at the significance of these antibodies. And then we also do what we call a DSA and a single antigen testing for specific cases, but the most important really is a cross-match. This is probably something that you will leave to the nephrologist to help you with. And this is how the CDC cross-match is done. Really, it's about introducing donor lymphocytes to the recipient serum. And if the recipient has antibodies, those antibodies will bind to these lymphocytes, and then you add contrast, and then there will be holes which will be poked into these lymphocytes. You add a dye. If a lot of the lymphocytes have dye in them, then it means they have holes, and it means there's a lot of antibodies. So this is something really that probably most of you would not be interested in, would be something for the nephrologist to help you with. So at the end of the day, for us at our practice, we do quite a number of things, and we go in stages. And as you can see above, for the recipient, it starts with the doctor. The doctor has to decide whether the patient is going to benefit from a transplant. Then we do the malignancy workup, we do the cardiac workup, and then we do the rest of the workup after that. So this is probably a template that we use everywhere. I think for Eldoret, this is what we use both in private and at MTRH, and it's similar to what other people use around the country. So for our patient, I think the patient was 62 years old, so that sometimes brings alarm bells. Where we trained in Cape Town, we used to have this rule that a diabetic who is older than 50 will never be considered for a transplant. But in our country, we have to look at every case. You have to look at the case it's person-centered medicine. So look at the patient in front of you, look at their social circumstances, look at the donor. Now, being a family member, you worry about them having diabetes as well. So you should closely look at that. And then the blood transfusions bring an alarm bell. The more transfusions you get, the higher the chance that you'll develop HLA antibodies, so that's something of concern. The diabetes is something of concern, so that's a patient probably that, this is a patient we'll have to assess thoroughly in terms of cardiovascular workup before we clear for transplant. And then we'll also look at any malignancies that might be going on. So at the end of the day, really, the thing that I wanted to tell you is that CKD is a menace. It's really currently an epidemic. I think for most of you, all your dialysis units are full of patients, and really it's time that we consider transplant, which offers the best outcomes for patients in terms of quality of life and survival. And every patient deserves to be offered a chance of transplantation, and every physician, each and every one of you, should be really conversant with the basic steps in choosing a transplant recipient donor pair. So thank you very much. I apologize for going over time, but being the chairman of the North Rift, I think I deserve some, thank you very much.
Thank you very much, Dr. Matthew Koech. I think we'll have to consider your apology, but thank you for the presentation. I think the message is home and clear. So here I want to introduce to you the next presenter, Dr. Jonathan Wala. Dr. Jonathan Wala is a nephrologist at Aga Khan University Hospital. He did his training at the University of Nairobi and did his certificate training in nephrology in Stellenbosch University, Cape Town. He's the current president of Kenya Renal Association, and as we all know him through the various forums, he's a strong advocate for kidney health, and his goal is to make kidney treatment and accessibility of treatment equable to all parts of our nation. So welcome, Dr. Wala.
Thank you, Dr. Maritim. Good afternoon, everybody. Greetings from the nephrology world. We've had two nice presentations before me. And my role is to remind us about the role of us as physicians in championing for kidney health. We are having World Kidney Day in 6 days' time. Next Thursday will be World Kidney Day, but actually we take it as a World Kidney Week to remind us of the importance of our kidneys. The theme this year is kidney health for all, and ensuring there is equitable access and ensuring that there is as much availability of medications for kidney disease patients. We are doing this in the background of the fact that we are having serious health financing challenges in Kenya, and this has especially affected dialysis units whose only source of revenue is through the NHIF system, and therefore when the NHIF collapses, dialysis units collapses, and then after that the patients also collapse. 12 years ago, 13 years ago, before this NHIF program came in, it was basically a death sentence to have kidney failure. When somebody gets kidney failure, they come, they pay the first dialysis catheter, temporary usually, and then after that they pay the first dialysis session, they borrow from the neighbor, they pay the second one, they borrow from a chama, they pay for the two remaining ones, and then they organize a small arambe, they pay for the rest of the month, and then the second month they begin auctioning their things, basically paying for the dialysis. Eventually they sell a plot, and then after 3 or 4 months they die and leave the family in debt. That is a situation where we are going to go back to in a few weeks' time if we don't put our houses in order. In the background of this is the fact that kidney disease is often silent and affects quite a majority of people, as you can see. And thirdly, that kidney disease is been labeled as if it's dialysis as the treatment for kidney disease. Yes, there are many, many things that you can do to prevent this bad outcome of dialysis. My disclosures is being sponsored here to come here by Microlabs. I have another disclosure to my physician colleagues. I'm not a dialysis technician. Please don't call me to write dialysis instructions. Call me to prevent dialysis from happening, and also call me to manage the patients for you. Dr. Joyce, you agree that? Don't get called for dialysis instructions only. These are basic outline. And I'll start with it's more of a political talk, and Dr. Getambu, my senior, is there, and she'll join in the politics of this discussion. Basically, we have sustainable development goals by the United Nations to ensure that we have better improvement in the welfare of human beings in terms of ending poverty, protecting the planet, and ensuring that by 2030 all people enjoy peace and prosperity. It looks far away, and now it's only 6 years, actually 5.5 years to time when 2030 will be there. Of interest for us is the Sustainable Development Goal number 3, where it's good health and well-being. That's the aim, the goal. And the goal is to ensure healthy lives and promote well-being for all at all ages, basically equity and health being the key messages. There are several targets in this SDG 3. The most important that we have looking at for us as nephrologists is the target 3.4, where it is reduced by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. And the second one is the universal health coverage, including financial risk protection. And that is an important part of this. Usually there's catastrophic financial problems whenever people get sick, and it's affecting huge and huge segments of the society. And this target 3.8 is to cover the essential health services. And we believe dialysis and the medications that prevent kidney disease from getting worse are part of essential health services. And also to avoid large household expenditures on health. And already you can see we are being taxed in one way or the other. And this tax for health is basically, it's not a tax, it's something that you have to do. If your child is sick, there's no other way you can do. You'll have to forfeit your food to ensure that child remains alive. Underpinning this target 3 is two equally important approaches, the primary health care and the universal health coverage. Almost meaning the same thing, but with a bit of differences. Primary health care basically is involving a multi-sectorial approach of the whole government and whole society. It's an integrated health services with multi-sectorial policy and action, empowered people and communities, and integrated health services to meet people's health needs throughout their lives, basically focusing at as big a number of people, as many options as possible, and at the person level. We actually often talk about the patient-centeredness of healthcare, but this is the people-centeredness of healthcare. And then it also creates the foundation for the achievement of universal healthcare, because people's needs and preferences are being focused on. You focus on them as early as possible along the continuum of care, right from the health promotion to prevention, diagnosis, treatment, rehabilitation, palliative care. And palliative care is there in kidney disease also, and also as close as possible to people's everyday life. So UHC basically means that all people have access to the full range of quality health services when and where they need them, without that financial hardship that you have talked about. And we have said it has to be a full continuum of care. And I like this continuum because it's explaining that you're not just focusing on the health only. Can I get treatment that helps me get better and safe? That's what we're always concerned about. But we are not looking at the things about, can I afford it? Can I get medicines and other health products that I need? Is it available? Are there policies in place to make quality services available to everyone? Right now the government is going through different policy measures, and we have been asked to be involved, but sometimes the apathy does not come from us alone. It also comes from the fact that the people who are involving you, they're involving you just for the sake of ticking certain boxes. So I hope that they can be ticked better. At the moment, the universal health coverage is considered to be like a cube where there is a population about who is covered. So at the moment there's coverage mechanisms here. There are many people who are not covered this other side. Sorry, go forward. And then also we look at another dimension of services. Which services are covered? Do you have enough of those services? Are they available? Are they accessible to these people? And then finally, the financial protection is very important as part of UHC. The patient is paying out of pocket. How much is it going to cost? How much of the household expenditure is going towards health costs? All this is because the burden of diseases, non-communicable diseases especially, is increasing more and more. And these are the deaths from communicable diseases since 2000. And you can see there's a progressive increase from 64% and going towards 74% by 2019. And it's expected to become even higher as the years go by. Unfortunately, communicable diseases are not getting fewer. So we are just exchanging for newer diseases, and it's because of many different reasons. And the percentage of total deaths attributed to NCDs is high in most countries. In sub-Saharan Africa, we consider it to be a little bit lower because of the burden of communicable disease, but we expect this also to go to increase. And therefore, we have to be prepared for this fact that there's a non-communicable disease epidemic that is hitting us slowly because of the changed lifestyle. They continue to kill a lot of people. Around 41 million people every year are killed by non-communicable diseases, accounting for 70% of all deaths worldwide. Of these deaths, cardiovascular disease accounts for 44% of them. It's quite a big chunk. Then cancer, respiratory disease, and diabetes contribute to 80% of these non-communicable diseases. So this all looks very glossy, and you can say that non-communicable diseases therefore are cardiovascular diseases, chronic respiratory diseases, diabetes, and cancer. Unfortunately, Martin and Joyce here will be really complaining because they can't see themselves here. So you wonder, where is chronic kidney disease? And I find that it's hidden inside these zones. The biggest cause of death in chronic kidney disease is cardiovascular disease. Most chronic kidney disease patients, most patients with cancer will end up having chronic kidney disease. You know that diabetes, basically 30% of diabetic patients will be chronic kidney disease also. So underlying these deaths from these four big guns, there is chronic kidney disease that is going on. And therefore, we want to improve the awareness of this burden of chronic kidney disease that is silent, and it's a potentially correctable target of lowering mortalities. The latest update in 2022 from a world analysis is that chronic kidney disease is extremely common. Up to a tenth of the world population has got chronic kidney disease. And this one we have already seen the definitions. Proteinuria or creatinine going up. A tenth of the world population has got chronic disease. And there's more prevalent, unfortunately, in women, in the elderly, individuals with diabetes, the racial minorities, and individuals with hypertension. Basically identifying risk factors for chronic kidney disease. Therefore, people whom you can screen for and follow up with more attention because they are going to end up with chronic kidney disease. And you can look at the number of deaths attributed to chronic kidney disease. 19th in 2013. By 2017 it was 12th. But last year it was around 10th or 8th. And now it's going towards 5th in the next 10 of 20 years. So eventually joining those big four that you're talking about, there'll be a big 5. And chronic kidney disease you have to be aware of. It's among the top 10 causes of death in several countries, including Singapore, Greece, and Israel. So in some countries it's already overtaken some of these other chronic kidney disease. And therefore, chronic disease occurs frequently and has devastating consequences. But CKD is beyond non-communicable diseases because it also has other causes, including infections. And HIV drives chronic kidney disease, not just the disease itself, but also the treatment, the medications used. Tuberculosis, malaria, hepatitis B and C, a common cause of glomerular problems affecting chronic kidney disease. Parasitic disorders, including schistosomiasis, causes chronic kidney disease. We have got a big burden of alternative medicines, including traditional medicines. And then you have got counterfeit medicines getting in. You're not sure whether the amoxicillin that the patient is going to get is correct or not. The cough syrup problems, etc. And then there are pesticides that are being marketed that they are for killing weeds. There are pesticides for animals. There are animals that are being slaughtered when the pesticides are still inside them. We are eating eggs from chicken treated with antibiotics. All those are important. And here in Eldoret it's very clean, but we live in another garbage camp called Nairobi. And there's a lot of industrial waste products and the heavy metals, etc. And therefore it's a whole. But then therefore chronic kidney disease is not only just an non-communicable disease, but there's also linkages with communicable diseases, and of importance because of this climate awareness world we are living in about environmental factors, especially pollution and toxins. CKD itself is a continuum, and there are different types. We know of acute kidney injury and you know of chronic kidney disease. Basically, the cutoff is after 3 months of having kidney disease, you become chronic. But in between, we have noticed that there are some patients whose kidneys don't improve after acute kidney injury. And these are the patients that we say they have acute kidney disease. Basically, the patients with with renal failure that you meet in the hospital could be patients who didn't have kidney disease in the first place, no kidney disease, NKD, and then they got acute kidney injury. If they get acute injury and they recover with it within a period of 1 month, then those patients have got acute kidney injury true. If they progress beyond that period, then these patients have got acute kidney disease. And they are especially an important segment of a missed population, because you tell the patient, because the creatinine has come down from 300 to 100, then they have recovered. But this patient's baseline creatinine was 60. And if you do a simple maths, 40 divided by 60 is 2/3 loss of GFR for you to go from creatinine of 60 to 100. And these are patients who are missed, and therefore they are not followed up. They are not told to come for the clinic because they recover their kidney function. They'll be our clients in 5 to 10 years' time, and therefore we have to be aware of that. Therefore, they have got important outcomes. Even these patients who don't have recovery from acute kidney injury, they are already predisposed to more cardiovascular events. And in fact, in 10 years' time, they are more likely to be dead than somebody who didn't have acute kidney disease in the first place. So it's an important segment of the population to capture. Chronic kidney disease itself, it's a continuum. And this slide is to show that it starts from a normal stage to increased risk. Basically, you have got diabetes, hypertension. You are said to be at risk of kidney disease. And then there is damage, which is now histological damage. You don't notice it by a rise in creatinine. By the time we reach here where the creatinine is rising, you have already missed several steps of intervention where you could have intervened earlier. And finally reach a place where there is kidney failure. And kidney failure is where now you call us as dialysis technicians to tell us we need this patient to start on dialysis. It's rather too late. There's nothing you can do. The horse already bolted, and now you're just preventing death. But Lord says death is inevitable, 100% mortality for all of us. So quality of life is what we'll be looking at that place, at that time. It offers us, therefore, an idea of when to begin looking for these patients. And as early as possible. In fact, if possible, screening populations at risk for chronic kidney disease becomes important. But all these are the times you can still get interventions that will help somebody decrease the chances of dying and improve the quality of life also. This CKD stage 5, therefore, is basically the tip of the iceberg. We fail to pick up all the other stages because you're focusing on the dialysis patients. And these dialysis patients are actually a small segment of the population. 80 to 93% of kidney disease patients are unaware of their diagnosis. And even when they are aware of the diagnosis, the targets for management are poor. Proteinuria monitoring, proteinuria is only around 55%. The IS is maybe RAS blocker use. Blood pressure control is poor, and this is where Dr. Koech, Peter is angry about the rest of our medics, that expert nephrology advice is only 20-30%, quite low. Therefore, you have to be aware of the fact that we have interventions that you can do for this. What are therefore the benefits of screening? To reduce morbidity and mortality from CKD and its related complications. That's the main benefit. And also it also informs treatment decisions, how to slow or halt the progression of CKD, especially how to reduce cardiovascular disease risk, to improve lifestyles and dose modifications, for example, of medications where appropriate, especially for example, cancer medications have to be adjusted for the kidney disease patients. And therefore, ultimately to reduce the financial burden, because it's cheaper to prevent kidney disease than to treat kidney disease. Kidney disease basically is a sentence to financial problems again and again and again. Even if you do a transplant, you continue bearing a financial cost. Even if you transfer it to the health system, the government, then the government bears a big cost. And you have seen this with NHIF having problems sustaining the dialysis program. There are different criteria for screening, for CKD being deemed as a screening criteria. It's an important health problem. There are acceptable treatment options for people who have got chronic kidney disease. The facilities for diagnosis are there. There is a latent or early symptomatic stage which is quite long of CKD stage 1 to 3, and there's a suitable test or examination, that is a creatinine or a urine albumin test, basically urinalysis, pro-urine protein. If you can go a step ahead and do a urine albumin protein ratio, becomes even better. 24 urine proteins unless you're thinking of severe nephrotic syndrome. Also, there is the test is accepted to the population. It's an urine test. It's only a blood sample. You're not doing investigative tests like doing an endoscopy or doing a CT, coronary angio, like doing a stress test, difficult things. There's simple things to do. The natural history of the condition is well developed and it's known. You start from a risk, you go to injury, you progress to disease, and then you're progressing towards failure and death. There should be an agreed on policy on whom to treat as patients, and that's what we are trying to base ourselves on. Cost of case finding, is it acceptable? And the cost, there are studies that showing the cost of doing urinalysis, screening for CKD in the population might outweigh the benefits, and therefore it is important to target who to treat. So who should be screened in chronic kidney disease? There's those with risk factors, and risk factors that we know of, diabetes and hypertension, are obvious. History of acute kidney injury should be there, up there. You should screen for that. Cardiovascular disease, anybody with cardiovascular disease should be screened for chronic kidney disease. Certain ethical and racial minorities in this racial disparate countries, obesity is an important cause of chronic kidney disease. In fact, there is a glomerular problem associated with obesity, and all chronic kidney disease problems, they advance with obesity. And obviously, elderly people will have kidneys that are not able to adapt to problems. And how do you screen? A urine test for albumin and a blood test for creatinine to estimate the GFR, as you have said before. And from screening, you make a diagnosis, and Dr. Koech has already given you this heat map, where as you get more proteinuria and as you get less GFR, you get to be a higher and higher risk. And this risk is not risk only for kidney failure, it's also, one slide back. For sure. The chair has asked me to come here so that he can take me a photo. 5 more minutes, you're adding me. You're done, huh? Yeah. Okay. That's for Kenya Renal Association. So, this increased risk is as a result of the combination of increased creatinine and increased protein. What does the risk mean? It means that you need to refer more likely to a nephrologist if you're at high risk. The other risks, which is a majority of the patient, the rest of the iceberg, is what we should all be learning to manage. Not only looking at the cardiovascular disease containment, but also CKD progression, which also increases cardiovascular disease more. Okay. So in the primary healthcare setting for chronic kidney disease in a country like ours, what do? You get those ones with risk factors up there in that first box, and if they have any risk factors, then you screen with a dipstick proteinuria, and then you go to more specific tests if they are suspected to have this positive, and then if it's confirmed, you stage the kidney disease, and then you begin to stratify the risk of the patient in terms of the stage of the kidney disease, and you decide on treatment or on follow-up. And that's what we all expect, that at every primary health system, it should have that. The treatment itself, they are well established. This is taken from patients with chronic kidney disease and diabetes. But it will fall for, it will also apply for anybody with chronic kidney disease with proteinuria. That means if you have 2+, 3+, or 4+ chronic kidney disease, these same treatments for diabetic nephropathy are applicable. The first one, obviously, everybody knows about is SGLT2, and you have already inhibitors, and you've already heard about that, the sort of miracle drug of our modern era, and therefore everybody should be on it. And then we already have the armamentarium of RAS inhibitors, either an S inhibitor or an angiotensin receptor blocker. ARNIs have recently also been shown to be able to delay the progression of chronic kidney disease. You cannot avoid blocking the mineralocorticoid system, and especially for chronic kidney disease in diabetes, there's now good evidence from last year's trial of non-steroidal mineralocorticoid receptor antagonists, specifically finerenone, in preventing the progression of chronic kidney disease and preventing the progression of chronic cardiovascular disease. It's reaching to the point where when we talk about MACE, everybody understands MACE, which is major adverse cardiac events. At the moment, the clinical trials are focusing also on MEC, major adverse kidney events, and they're becoming more and more important. Say 3 minutes, 4 minutes. Apart from that, the normal spironolactone can also be used for preventing of kidney disease. And don't forget the cardiovascular disease prevention, including statins and antiplatelets. So what is the comprehensive management of kidney disease? It's a busy slide looking at the pathophysiology itself, but basically focusing on primary CKD prevention, secondary prevention, tertiary prevention. We don't want to be here at the tertiary prevention. We want to ensure that all these other things are taken care of much earlier on. And it's very important. And therefore, identify high-risk persons and manage obesity, improve glycemic and BP control, avoid high-salt diet, encourage healthy food and lifestyle before we progress to the medications. And these ones should be done so that we don't reach to a pointless where you're talking about managing advanced kidney disease and thinking about kidney failure. So this is screening and lifestyle changes. Then followed by primary health care. And then secondary health care is here. By the time we get to the tertiary health care, it's usually too late for the patients. We need to have involved ourselves much earlier. So there's a continuum of care of chronic kidney disease from basically not just focusing on the renal replacement therapy, which I don't know it is here, renal replacement therapy in the slide, but looking at all these other ways of managing kidney disease. Of importance, there is increasingly an awareness that there is importance of palliative care in advanced kidney failure to ensure that patients still have quality of life. It's not end of life care, it is palliative care to stop, reduce the frequency of dialysis, things that do not add quality of life to the patient. So chronic kidney disease burden is more than just healthcare. There are other things like exodus of medical professions. There are limited resources. There is inadequate health infrastructure, geographical accessibility issues, insufficient personnel in the healthcare, etc. And therefore we have to be aware that when we are looking at the CKD burden, it's not just a healthcare problem, but it's a whole people problem. There are barriers to appropriate medication prescribing and use in chronic kidney disease, and they range from all the factors that are involved in provision of these medications. There's a deficiency of healthcare worker forces. You can see in all departments from, this is quite an unclear slide, but this is medical doctors to nurses, to dentists, to pharmacists. You can see in Africa we are ranging around between 0 and 10% of the population. I'm finishing just now. So how come we are transferring our personnel? Especially, it's sad for us that experienced dialysis and ICU nurses are going abroad in droves, leaving us with the inexperienced ones. We don't know what the healthcare system will handle. There are important social determinants of kidney health that you have to be aware of, and that you have to realize that you are living in a community, and that's why I call this a political talk, because it's to put the doctor back towards being a leader in the community, trying to look at all these things, not just trying to care of that patient individual. Able CS wrote this article in Business Daily and talked about SHA, the health financing of Kenya. I put it as health financing 2.0. I'm basically looking at primary health care fund, social health insurance fund, and emergency chronic and critical illness fund. And we have already been told by Dr. Turanira the day before yesterday, about these issues. Therefore, primary healthcare fund, we are seeing the role will be mainly in screening, urinalysis, creating, and this can also even be done by a community health promoter, those ones who are coming to the households. Blood pressure measurement, blood sugar measurement. If they can have a weighing scale and a height stadiometer, it would also be nice. Social health insurance fund now comes in more in prevention of progression of kidney disease. Immunosuppressive medications, you know that for glomerular disease or immunological problems, hemodialysis, peritoneal dialysis, transplant, and now for NSAID kidney failure. But we also have to ensure that these patients, when they are requiring these services, they are not blocked for the fact that they cannot access them. And therefore, in the emergency part of the critical illness part, then we have AKI management. Dialysis catheters, vascular access, PD catheters are often a roadblock towards somebody accessing dialysis. You can have NHIF coverage at the moment, but because you cannot afford me placing a catheter in you cannot do dialysis because it's not covered by it. Therefore, we expect that they'll be able to cover this. We have issued these things to them. We hope that they'll be adapted. We have seen some modifications in the SHA regulations that we are surprised that have come in, but we hope that they'll still be able to. Therefore, we did champions for CKD, champions that will encourage education, as you have said, encourage interaction with the healthcare system, etc., basically advocates for chronic kidney disease. So UHC in healthcare, we have talked about at risk of chronic kidney disease. We need to improve that population. We have to increase the services involved in screening, in promotion and prevention, in treatment. We have to ensure that there's proper healthcare financing. And it's only you as individuals here who can push, not only just directly speaking to each other, speaking to the people in government, but also advocating through the public. But because we have realized ultimately when the public complains, the government reacts, and that's the only way you can do it. I leave this last slide here, that the primary determinants of disease are mainly economic and social, and therefore its remedies must also be economic and social. Medicine and politics cannot and should not be kept apart. That's by Dr. Rose. Thank you very much.
Thank you very much, Dr. Jonathan Wala, President of Kenya Renal Association. We are pressed for time and we should be moving into another segment, neurology segment, but we'll have a very brief Q&A session. I'll invite approximately maybe 3 questions, and then we just move in for 5 minutes. So if you have a question, I should be able to extend the mic. I welcome the panelists to the front.
Good evening. I'm Chris Owino, resident in internal medicine at Moi University. And I'd just like to say a thank you to the eminent panel of speakers for the excellent talks. I have 2 questions. One to Dr. Wala, as the president of Kenya Renal Association. We recently carried out a study at MTRH, and we were just trying to pilot an educational intervention targeting pre-dialysis CKD patients. And no current evidence, at least in our setup, to show that there are any long-term benefits, but other studies have shown that that can actually help to achieve some of the targets you've shared in the secondary phase, where you're trying to halt the progression of disease. So my question to you is, what's the position of the Kenya Renal Association on that, the role of education in trying to achieve and leaving no kidney behind? And then my second question is to Dr. Koech, and it's about when a general physician is trying to refer a patient to you for transplant. So if I get a patient who's hepatitis B positive, is there anything I should do before? Are they supposed to be on treatment? What kind of hepatitis B and CKD or ESRD patients qualify for transplant? Thank you.
Okay. 2 more questions, and then they can answer all together.
Good afternoon. Thank you for the opportunity. I'm Dr. Sharif. I'm the physician from Wajir County Referral Hospital. So I'm supposed to ask 1 question, so let me say it's 1 question in 3 questions. So the first question is about donor suitability. I had a patient who was ready to donate his kidney to his wife. They went to India and they were incompatible and they had to come back. Do we have a program whereby we can screen them first, find a suitable donor, and maybe if they transplant, they go with that 1 person? The second question is about being the superhero physician. So if you are now like only 1 physician and at the clinic you are seeing all the patients and we have all these dialysis patients, what is our role in trying to still take care of these patients? And the third quick question is, we've heard about diet and in primary prevention of especially CKD patients. They have a different diet and you have to approach it differently. But I think we don't know so much about it, or like in a nutshell, how can we have like a summary, like for diabetes, you have the plate and then the doctor can quickly explain before they go to a nutritionist. So do we have like a small approach whereby you say, do A, B, C, D, just as you are seeing the patient? Thank you.
Okay, fine. Let the panelists respond to those. Maybe.
Okay, thank you very much for those good questions. Beginning with the one about education. It's good you're doing such a study, and I think there was one that was being presented yesterday. I don't know if it's the same one. It was an excellent study, basically showing that it is doable. As to the long-term outcomes, we are yet to see, but it is doable, and from other studies it has been shown that a well-informed patient is always a better patient. And you know this by basically colloquial experience. Whenever you have somebody whom you can explain to them and they grasp what they are a better patient in following instructions, in taking care of themselves, than somebody who is either not willing to learn or who is not able to learn. And there's no patient who, whichever their literacy level, there's no patient who is not able to be teachable about these things. If they are able, I also tell my patients or my colleagues, because the patients come with their relatives, and they say, this person doesn't know English, explain to me. I tell me, I'm explaining to this person, you translate for me, and if that person knows how to count money, you're able to learn things. So you just ensure that you have to pass on the message again and again. This education will, goes hand in hand with what he's asking about, the education about the diet. It's important to educate about lifestyle, basically, right from the early stages of chronic kidney disease. And the diet is in different stages and different variable implementations. The main focus for chronic kidney disease is the protein part of the diet, and obviously the low salt part of the diet. Fluid restriction may begin a little bit, potassium, phosphorus, but remember, when somebody begins dialysis, things change, especially for protein restriction. It has to go back to a high protein diet if possible, because low protein diet in dialysis patients is a killer of dialysis patients. And you have seen it again and again. When people continue the same diets they are in before dialysis, they continue them even in dialysis. Coming to the role of Kenya Renal Association, we are trying to ensure that there's more passing of the message, that the voice is a bit higher, the volume is stand a bit more, and the focus is a bit more on chronic kidney disease. How do you increase these voices? We increase this voice through what we're doing now, through educating ourselves. So we increase the voice through publishing guidelines. We already have some guidelines on different things. Some of them may need to be renewed, but in partnership with the Ministry of Health, we have set up a guidelines committee again, and we are doing those guidelines. Sorry for talking to me so long, but basically that's the short of what you're going to do.
Thank you. Chris, sorry, I forgot your question now. Sorry, I think Rosie came in and derailed my train of thought. I'm the chairman. Yeah?
Yes, so I was asking, at what point should we refer a hepatitis B positive patient?
Yes. So it was about hepatitis B infected patient. So the issue with hepatitis B really is about two things. You want it under control, and you don't want it to have caused HCC. So one of the basic things you want to do is you want to see whether it's active. So for us, we normally do the E antigen and we do the viral load, and we assess whether the patient is at risk of progression from that. And then of course we do the liver workup, the ultrasound and AFP. And if that is clear, then we can proceed. The next thing is, even if the patient is viral suppressed, once you put them on immunosuppressive agents, the virus is going to wake up. So those are patients who, after transplant, we normally maintain them. So the one patient that we've done, we maintained him on entecavir. And it's a very interesting case because the donor actually also was hepatitis B positive. He couldn't get any other donor from the family. Yeah, but doing well 5 years later. Now the next question was about, we understand that currently the physicians in the counties are taking on a lot of load because there are dialysis units in the counties. We don't have enough nephrologists to send to every county. Kenya Renal Association is trying hard. Yaki and the other foreign institutions are churning out nephrologists every day, but I don't think it's realistic that there'll be a time that we'll have enough nephrologists anyway in the country. So as physicians, you'll have to take some of the work and help us manage these CKD patients. And as well as said, the most important thing in CKD really is to think about what happens in CKD. These patients have a limited ability to excrete sodium and to excrete fluid. So early on, you want to limit salt intake, you want to limit fluid intake, so that they don't become overloaded and they develop hypertension and they worsen their cardiovascular disease risk. Later on, then you're looking at phosphate and you're limiting food rich in phosphate. You're also limiting food rich in potassium. And then later on, as they go into dialysis, the restrictions become a bit more severe. Personally, I don't subscribe to the low protein diet because of the danger of patients becoming malnourished, especially those patients who are of the nephrotic type, but that's a discussion for another day. The second bit you asked was about a donor-recipient pair who traveled all the way to India only for them to be rejected as being incompatible. So it's really important for you guys to understand what to do. More important, make sure the blood groups are compatible. Of course, deem the donor healthy. But of course, before sending them abroad, usually give a chance to us local physicians to have a look as well. KNH has a transplant program. Nairobi West, I think, Nairobi Hospital, Aga Khan, MP Shah, and then in Eldoret we have MTRH, and then we have the private groups, St. Luke's and Oak Tree. Medihill used to do, but I think Medihill now is out of the question. So I would strongly recommend that before patients get sent to India, advise them to at least seek the opinion of one of these local nephrologists, because one thing that they could have done for that patient is, after all the basic workup, do at least a cross-match. And most of the time, patients fail on that. The cross-match is positive, you cannot proceed with a transplant because the patient has developed antibodies, and that probably could have been sorted out before they got to India. So I think the quick answer is really talk to your patients and advise them to seek one of those centers for just a look, even if they still want to go. We don't refuse any patient. Personally, I don't discourage any patient. I tell them, look, you have options. You can transplant in Eldoret. There are 2 hospitals. You can transplant in Nairobi. There are 4 or 5 hospitals. You can go to India. You make the choice. But at least seek our opinion and seek our advice. And I know the Indians will also redo everything, but that's okay. What are any comments?
Okay, I just wanted to tell you, Dr. We actually have a study about patient education in nephrology patients. So my study was on vascular access related quality of life. And we saw that patients who are referred to see the nephrologist at least 3 months before they're required to start hemodialysis were well informed, they chose the right access, and they had a better quality of life. So we have studies, they're just not published.
So thank you so much. I want to bring this session to a close. So let's have the photographer. And I want to thank our 3 speakers, Dr. Matthew Koech, Dr. Jonathan Wala, and Dr. Joyce Bombegi. Thank you so much. Let's give them a big round of applause. And also our session chairs, led by Dr. Peter Maritim. So let's have the photograph. Where's our co-chair?
I'm here.
Your 2 chairs. Where's the one? It's gone. Ah, okay, no problem. Okay, so we'll quickly shift gears now to neurology. We have 3 talks lined up in neurology, and I'm going to introduce our session chair. Please, let's have the first slides up, please. So the chair for this particular session is going to be Dr. Sylvia Mbugwa, and she's a consultant physician and neurologist, assistant professor at the Aga Khan University Hospital, and also head of section in neurology. And she's going to introduce our 3 speakers and run the program for this particular block. And then from there, we'll conclude. Then Dr. Roslyn will give us some announcements. At the same time, we have research running upstairs. So also we have some talks which are going on in terms of research. You can look at the program, and those who are interested, you can go up to 3rd floor for those particular talks. So over to you, Dr. Sylvia. Thank you.
Good afternoon, everyone. So thank you, Eric, for your kind introduction. I'm the chair of this session, but I also wish to introduce Professor James Joey as a co-chair, despite him being seated in the audience as my mentor, and he's been a big driver of neurology formation in this country. We're actually very few neurologists. We're only 18 in the entire country, and we began a fellowship program in Aga Khan. And I would like to encourage as many physicians as possible, please enroll for neurology, because at this rate, we are going to become a very high attrition. Who's going to treat the next generation of Kenyans? Because as I stand here, I think I'm the last line of defense, in addition to some of the fellows that we are training. We actually have 4 fellows right now, and we hope that the program will continue to grow. So our speakers for today, 2 of them are actually our final year residents at Aga Khan University Hospital. They will present their dissertations, and 1 is our fellow, recently joined. She will present a topic. So I want to introduce Dr. Tabi Sika. Tabi is our final year resident. She's going to present thrombophilia, a case of cause of cerebrovenous sinus thrombosis. And I want to emphasize that neurology is thought to be a very difficult space, but because we are so few, we will have to rely on physicians everywhere in the machinery to actually be able to pick out these patients, identify them, identify the problems, and if you can't manage, please refer them, because if we get them early, just like renal patients, as well as said, we're able to make a difference and save lives. Thanks. Welcome, Dr. Tabi.
Good afternoon again. My name is Dr. Tabi. I'm going to take you through my study. We retrospectively reviewed patients managed in our facility with cerebral venous thrombosis. My conflict of interest is I was flown here and accommodated by Cosmos Pharmaceuticals, and I thank them greatly. I'm sure every resident understands. So the background is that CVST, it's a cause of strokes. Very common in young adult females. The literature that is found internationally is that it's precipitated by being on your combined contraceptive treatments, infections, and having a thrombophilia, whether acquired or genetic. We need timely diagnosis, and we need to have prompt neuroimaging and guideline-based treatments to have good outcomes in these patients. So the AHA, the American Heart Association and Stroke Association have released a statement this month on the diagnosis, management, and of CVST. And just to give you a brief background, is this your venous sinuses, and the commonest in their study was found to be the superior sagittal sinus, followed by the transverse sinus. When this was the guideline on how to investigate these patients. So when you have a clinical suspicion based on your history and physical exam, you do either an MRI, T2 weighted with MRV sequences, or you can also do in different resource settings, you can do a CT head with CT venograph. Once you have a CVST confirmed, you need to investigate this patient, look for what is causing it. Is it the infections, the medications, and you need to do specific targeted tests to identify the risk factors and the causes of this CVST. When we look at the literature coming from our region, there's a large systematic review, large in terms of this is CVST, it's a rare disease, which looked at sub-Saharan Africa, all of these countries, with a total of 287 patients. And in this systematic review, if you can, I can't figure out this pointer. If you can see, the Kenyan was done by our able colleagues in Kenyatta, Onyambu et al., and they only had 53 patients. 51 of them was in a case series, and 2 of them were from a case report. So justification to do this study is that there is scarcity of data in sub-Saharan Africa. And when we look at Onyambu's paper, he looked at clinical factors in neuroimaging findings. He didn't look at management or outcome. The commonest risk factors they have was infections, including HIV. And when we look at the data that we got in Aga Khan, we found different results. So our objective was to look at what proportion of patients had a good outcome. So outcome in strokes is measured by the modified Rankin score of 0 to 2. The score goes up to 6. So if your score is 0 to 2, you have a good outcome. The secondary objectives was to look at the risk factors, treatment outcomes, neuroimaging findings, and then compare management that we gave our patients to what is being used internationally. It was a descriptive retrospective studies. We looked at the patients who are managed or diagnosed with CVST in Aga Khan. We looked at them 13 years retrospectively with appropriate approvals, and we used REDCap to collect data and analyzed using SPSS 22. So the baseline characteristic was we had a median age of 36.8 years. 67% of our patients were female, and more than 80% of African ethnicity. The commonest presentation was headache and visual problems followed by seizures. The median time from symptoms to diagnosis we found to be 6 days, which was of significance that these were very sick patients who came into hospital early and got their diagnosis in time. We found that 45.9% of these patients had non-communicable diseases, with hypertension being the commonest cause at 16%. Of interest is that we found a whopping 30% of them had thrombophilias, and 8.2% had malignancies and autoimmune diseases. Comparably, of the infections, 18% were noted in our study, with only 6.6% having HIV and the rest of the other causes. I'll show for women, because this is interesting and important because it's a disease common in females. Pregnancy, we had 14.6%. This is pregnancy, postpartum, and related complications. And of the combined pills, we only had 8.5%, which is significantly different from the data that was provided. When you look at the breakdown of the thrombophilias, the commonest we had in our setting was the protein S deficiency. We even had a patient with heterozygosity to prothrombin G20 to 10. So when you compare to the AHA statement that was released, their commonest risk factor was oral contraceptive. They had 54 to 71% of the female population. We only had 8.5% of our population. The rest of the other end of significance was the pregnancy at 11 to 50%, and the other causes. Infections was not that exciting at 8 to 11%. So when we look at our imaging that was done, most of our patients had MRIs done, with the superior sagittal and transverse sinuses being the commonest. There were more than 2 sinuses involved in most of the patients. And of significance is the commonest secondary pericardial lesion was hemorrhage. 83%, which is a bit of significance, of the patients were re-imaged, and only 53.9% had complete resolution of the scan at the time of the last image, which was done about 3 to 6 months after starting of treatment. Our patients, 50% were on warfarin, the rest were on your DOACs. We had one patient on fundaparinux because they could not tolerate warfarin. Of the ones on rivaroxaban was 29.5%, and those of dabigatran were 14.8%. When you look at the most recent trials, there's a RESPECT trial, which came out, I think, in there's a RESPECT trial, which looked at dabigatran, and it showed that dabigatran is equal to warfarin in terms of treatment. The RESPECT trial looked at rivaroxaban. There was just one major event that happened in the rivaroxaban trial group, and they showed that overall, there was still a good outcome of the patient with on rivaroxaban. There's another trial, also called the ACTION trial, that looked at 3 DOACs. That's apixaban, which was at 67%. It looked at rivaroxaban and dabigatran, and it's basically saying that we may now shift from traditional warfarin, and we may be able to put the CVST patients safely on the DOACs. Of our outcomes, MRS is modified Rankin score. It's scored from 0 to 6. We had a very good amount of patients who had a good outcome at 92.7% with a modified Rankin score of 0 to 2. We only had one fatality, and this was related to malignancy. So this is the largest known case series in the region. And we looked at both causes and outcomes, and we found that actually infection, unlike what the systematic review found, they found infection was there in 63%. We found in only 18% was not a major factor. What was of significance is that we had a significant number of patients who have thrombophilia. Contraceptive use was not really that much in our population, and the multiple risk factors was noted in patients. We had a very good proportion of good outcomes, and we can say this is because when we looked, there was a the median time from system to diagnosis was 6 days. That's commendable. There was appropriate imaging done, concise patient referral and treatment, and aggressive management of the complications with good follow-up. Limitations was that this was a single private tertiary hospital-based study, and this offered selection biases. We also were unable to do sub-analysis because we had a small sample size. We recommend that you screen your patients for thrombophilias, look for malignancies as an underlying cause. Hemorrhage can be a CVST, please look for it, and you can safely use dabigatran and your other DOACs. So in conclusion, again, we showed CVST is predominantly in young female, and thrombophilia is actually more in our population than the blood-borne viruses and CNS infections. You have more than one risk factor. Kindly screen for more, and please screen for the patients at high risk screen for malignancies because it confers a worse outcome. Contraceptive use is not that of significant in our population compared to the West, and most of our patients were appropriately managed with only half of those with complete resolution of the CVST. And of significance is that we had a high proportion of good outcomes. I would like to thank my supervisors, and I'd like to appreciate all the women here today as we celebrate International Women's Day. As for the men, you can celebrate with us in proxy. Thank you.
Yes, happy International Women's Day, starting with Rosie and everybody else. So I think we'll keep our questions to the end, and I'll invite our second speaker. He's called Dr. Zian Wikamba. Zian is also a final year resident at the Aga Khan University Hospital, and he will present his dissertation, Idiopathic Intracranial Hypertension. This is such a crucial topic, and we really miss out on these patients. And as Zian will tell you, let me not take away his thunder, the greatest risk of this is that they are mostly young females and they lose their vision. And they are very easily diagnosed. We just need to have a high index of suspicion and actively look for them. So not every headache is a migraine. Thank you. Welcome, Zian.
Good afternoon. Thank you, Dr. Mbugua, for the introduction. You always aspire to be neurologists in future. So this is an appropriate study to actually discuss on International Women's Day. It's a condition that affects women. And as it has been pointed out previously, we are severely lacking the number of neurologists. So this is a condition we'll have to pick quite frequently as practicing physicians. The second thing I would want to point out from the outset, we are usually taught in patient care, first do no harm. But this is a condition, if you don't pick it up, omission will actually lead to patient harm. So you need to keep a close eye on patients and pick this up early. So I have no conflicts of interest to declare. So as a way of introduction, idiopathic intracranial hypertension, it's a clinical syndrome that is characterized by elevated CSF pressure. The confounder here, there's no demonstrable secondary cause and no demonstrable obstructive cause. As it has been pointed out, this is a condition that is known to affect women, especially in their childbearing years. And these are women who've had recent significant weight gain and or are obese. The constellation of clinical findings and symptoms that are used to usually identify the condition are usually a bit confounding. And this modified Dundee criteria has actually been validated to pick up most of the patients. I'll just discuss that in this table. And I like to look at this table beginning with a point at the bottom that patients who present with IIH are usually awake and alert with no focal neurological findings and no obvious disability till they get visual compromise. So these patients come with symptoms of raised ICP. They'll complain of headaches. The problem is when they tell you they have a headache, the headaches usually have varying character. They are not the typical headaches that will point to a specific syndrome. They also come with what is described as pulse synchronous tinnitus, and these patients complaining of feeling of flowing waves in their ears, which when I first read about this when I was a first year, I found that quite interesting because I could not comprehend how, as a physician, you would understand what the patient is actually telling you. The other complaint is usually visual obscurations, and this can range from photopsias to diplopia, etc. And the most important thing that I have to point out is the papilledema. Because as it has been pointed out, outside of Nairobi, getting neurologists might be a bit hard. And as we'll see in the rest of the criteria, the workup is actually quite extensive. So if you can get a fundoscope, dilate your patient, do pupillary dilation, and look at the fundus. If you pick papilledema, you're halfway to your diagnosis and you can actually avert visual loss. Importantly, the patients have normal neurological examination, but some patients can have abducens nerve palsy, and this is usually related to the false localizing sign from raised ICP. Most centers advocate for MRI brain with an MRV if available, but a CT scan has actually been found to be quite sensitive in ruling out secondary causes. Lastly, you'll have to do, in patients you suspect to have IIH, you'll have to do lumbar punctures in the lateral decubitus position. And if you get an opening pressure above 25 centimeters of water, with normal CSF diagnostic studies, this is biochemistry, microbiological, and cytological study, you actually have nailed your diagnosis. So the problem with this condition is that if you don't pick it up, if you're not aware of these criteria, and patients actually have IIH for prolonged duration of time, as we'll see in a few slides, the patient will have visual loss. And the unfortunate thing about IIH, once the vision is gone, it's gone. This is actually usually irreversible. So, sort of a busy slide, hopefully not too complicated. So, the basic problem with IIH is raised intracranial pressure. And if we can start from, that's my right. The problem can be raised CSF production or reduced CSF reabsorption. So in terms of raised CSF production, there's usually this sodium-potassium channel and the aquaporin channel on the apical membrane of the choroid plexus. That is the image on the right. And this has actually been implicated to lead to increased production of CSF. And actually that is a therapeutic target with carbonic anhydrase inhibitors. There is a role for increased central obesity and increased adipose tissue. And it is thought, one, you have deranged 11-beta-hydroxysteroid dehydrogenase, which converts your cortisol to cortisone and that has been attributed to to inflammatory changes in the brain, which is actually at the top, with the role of adipokines. And what is thought to happen, you can have dysfunction of the arachnoid granulation in the superior sagittal sinus, or the raised ICP from all these causes can lead to stenosis of your sinus flow, and that will lead to raised intracranial pressure. An interesting concept that is coming up is the glial-lymphatic dysfunction, which has a huge role in reabsorbing CSF. So, sort of a similar slide, but I wanted to point out two things in this slide. One is the role of central obesity. And this is thought to raise intra-abdominal pressures and intrathoracic pressures. And also that has been attributed to reducing CSF flow. The problem with this theory is that one of the conditions that markedly raises intra-abdominal pressure is pregnancy. But IIH, interestingly, has never been associated with pregnant women. It's actually obese women. There is a lot of evidence that has shown us that weight loss, most guidelines recommend 15 to 20%, but actually even modest weight loss of about 6% has been shown to be actually a cure, and patients can actually be weaned off medication. So in our context, IH is still an infrequent neurological diagnosis. I had actually never heard of this condition till I joined Aga Khan, and I had been in school for 6 years. I found that quite interesting. The other issue we have to think about in our context is the issue of access to care. Because you need neurologists, you need ophthalmologists, you need neuroradiologists, you need MRIs, you need CT scans to just diagnose one condition. And of note, this is not a one-off consult that you get your diagnosis and you put on treatment and that's the end of the story. This is a patient who will have to be reviewed severally, and we actually found a huge dropout rate in this study. From 2019, there was a sort of increase in the cases after the COVID epidemic, and it was not clear whether this is because people became sedentary, gained weight after COVID, and there are actual studies that have shown that IIH might actually be a neurological manifestation of COVID infection. And it is thought COVID actually has an effect on the arachnoid granulations, but this is still very unclear with no solid evidence. Our literature review just showed us 6 studies. I think South Africa had 3, Tanzania had 1, and 2 in Northern Africa. So this was a retrospective cross-sectional study, and we looked at all patients who met the ICD-10 criteria for IIH, who are aged at least 18 years of age at the time of diagnosis, from January of 2011 to December of 2022. The thing I have to point out, when we started the study, we had not realized there are a lot of patients in their pubertal years, that is between the age of 14 and 18, who had actually been diagnosed with IIH, and we did not look at this because they're usually under the pediatric department at Aga Khan. So we looked at the clinical care journey, and we looked at the epidemiology, the clinical attributes, the workup findings, and the treatment outcomes of patients diagnosed with IIH. So the interesting findings, I'll just highlight the most important things. We found this to be a disease of exclusively females, with 92% of the patients being female. They were relatively young, with a mean age of 34.2 years, and most of them were obese, with a mean BMI in the obese range at 31. So the patient number trends that we picked up after when COVID came up, for context, between 2011 and about 2016, they used to diagnose 5 cases in a year. That's 1 case every 2 months. But when COVID came up, in 2019, there was this sudden increase in patient numbers, and we were diagnosing a case every 2 weeks. For what is considered a rare neurological disease, we found this to be significant. And the cases remained persistently elevated after that. I have to point out, though, in 2018, there was an expansion of the neurology service with the onboarding of 2 more neurologists, and this might have widened the scope and the rates of diagnosis. So about a fifth of the patients had significant weight gain in the preceding year before the diagnosis, and about 13% of patients had been diagnosed with metabolic syndrome. And this is also significant because, remember, these are patients in their 30s who are hypertensive, diabetic, they have central adiposity and all that. Virtually all patients came with headache at 93%. 63% had visual symptoms, and this ranged from visual loss to diplopia to photopsia. Significantly, only a quarter came with tinnitus, and actually tinnitus is the most significant clinical complaint that can direct you towards IIH. On the issue of delayed access, 29.6% of patients, that's about a third, had been reviewed severally with headaches with no clear diagnosis made. Again, about a third already had moderate papilledema, and this points to the direct risk of visual loss. 1 in 3 patients had a probability of being blind in 3 months if nothing was done. However, about a quarter of the patients did not have comprehensive examination, and by this I mean they did not have visual acuity, they did not have visual fields done, they did not have OCT done, and all that is required to lead to a comprehensive diagnosis. This is a screen grab. I hope it's clear. This is an MRI that had been done elsewhere and had been reported to be within normal. But you'll see there is flattening of the posterior sclera, which is the blue dots, and their optic nerve changes. And when this was looked at again, they actually changed the diagnosis to IIH. In our study, the median LP opening pressures was 31 centimeters of water.
Allow me to interrupt a bit because I don't think we'll go back to this slide. And all physicians have to be the first line of defense for these patients. So when you look at this slide, where Zian has pointed the blue dots, the sclera is actually supposed to be a nice globe. The eye, the orbit is supposed to be a nice globe. So what you find is flattening of the posterior sclera where the optic nerve is indenting into the globe. And you can actually see that if the blue dots are not there, you can see it's actually cut. And then when you look at the optic nerve, you can actually see there's that subarachnoid sleeve around. So instead of it being just one signal intensity, you actually find reduced intensity surrounding the optic nerve. And then when you look at a surgical cut, the sagittal is where you look at this cross-section. Coronal is like a crown, sagittal is like this. So you look at the pituitary gland, you'll actually see an empty cell. Because the CSF is so much, so it actually displaces the pituitary. So once you see those and the patient presents to you with headache, you actually make your diagnosis. But we'll discuss more this at the case discussion. Sorry, Zian.
Oh, thanks for the input. Sorry. So in terms of treatment, if you remember the pathophysiology slide, I had pointed out one of the prominent theories is actually your sodium-potassium pump on the apical membrane of the CSF production cells. And actually that is one of the targets that has been found to work quite well, with acetazolamide being one of the recommended drugs, and topiramate. However, acetazolamide most of the time will give you acid-base balance issues, and there is actually an issue of teratogenicity with patients who are below 20 weeks gestation. Topiramate has been also recommended. It's a weak carbonic anhydrase inhibitor, And it also has a benefit of weight loss, which is actually a big, has a big role in IH management. However, even the best of centers, there's actually no head-to-head trial, because if you put the patient on the wrong treatment, they'll actually go blind. So most of the patients, 76.6% reported improved symptoms. That's the headache and the visual symptoms at 6 months of follow-up. And 67% had normal visual acuity on examination. And this, I missed that. At the beginning of the study, 59% had abnormal visual acuity, but the moderate papilledema had come down from 32 to 12. And this demonstrates once your vision is compromised, once it's gone, it's actually gone. However, a very significant number, 38.2% were actually lost to follow-up for different reasons. Could be cost, could be the intensity of the follow-up, because you need a neurologist to see them once or twice a month, an ophthalmologist. They might require repeat scans and all these things. So weight loss. This is actually a cornerstone of management. And in all patient files, that's 100%. Patients were actually told weight loss is recommended. However, 56%, more than half, did not have a documented modality. That is, they were not told how to lose weight, how fast, and what is the target. Most of the patients chose to do a self-directed diet plan at 21%. 19% did a formal dietitian plan. And the results of that were rather disappointing, because you see the two graphs are almost similar, with a mean BMI at 6 months of 30.9. And this is actually 6 months apart. So, to the take-home messages. IIH is an increasing problem that we cannot afford to miss. We don't know the role COVID is playing, but we know with increased obesity in the world, we are bound to find more of IIH coming up. Even what I will consider a good center, Aga Khan, most patients did not have, not most patients, a significant number of patients did not have a comprehensive baseline assessment. We lost a lot of patients to follow up, and we don't know if they still have their vision. Nutrition and exercise should be standard of care, but more than half of our patients did not get this referral, and they failed to actually lose weight. And finally, we should actually consider the role of modern weight loss strategies. Are these patients we want to put on semaglutide, tirzepatide? Are these patients we want to refer early to bariatric surgery for weight loss? Thank you. I think I'm done. Oh, I would like to acknowledge my supervisors. There was Prof. Soki, there was Dr. Sheila Mako, who's an ophthalmologist, and my biostatistician, Dr. Jasmeet. And happy International Women's Day. Thanks.
Thank you very much. Rosie, I forgot. So on to our last speaker, Dr. Linda Barasa. Dr. Linda Barasa is an alumni at the Aga Khan University Hospital. She actually finished her residency. She worked in Avenue, and she's come back for neurology fellowship. She's actually our latest neurology fellow. Welcome, Linda.
Thank you.
She's presenting on a very bizarre set of cases. So just think easy and refer when you can't make head or tail of these patients. Thank you.
Thank you for the introduction. I will be speaking today on the spectrum of anti-GAD antibody-mediated neurologic diseases. This is an illustrative case series. And just as a disclaimer, I have a few patient videos and photos. And I do have their consent to present today, but kindly requesting that for those slides that you do not take photos or videos, but for the rest you're free to take. So to give a background, we know that GABA is the major inhibitory neurotransmitter within the CNS, together with glycine. And GABA is synthesized from glutamate using the enzyme glutamic acid decarboxylase, GAD. And GAD exists in two isoforms. We have GAD65 and GAD67. GAD65 is what has clinical utility. So when you have antibodies to GAD65, then you have a deficiency in GABA, and this results in a state of neuronal hyperexcitability. GABAergic neurons are basically all over the CNS, but they are located, there's a heavier concentration in the hippocampus, the spinal gray matter, in the cerebellum, and this corresponds with the clinical manifestations. So the neurologic illnesses associated include limbic encephalitis, autoimmune epilepsy. You can have psychiatric manifestations, particularly generalized anxiety and phobias. You can have cerebellar ataxia, and you can have stiff person syndrome and its variants. And as you can see on the right, there's a correlation between the level of serum GAD65 antibodies and the clinical manifestations. So at the higher titers of serum anti-GAD antibodies, you can have the neurologic manifestations, which can happen as individual illnesses or as overlap syndromes. And with the lower GAD65 antibody levels, then you have an association with type 1 diabetes, and indeed it can happen even in a healthy population. This table was to highlight a few things. First, that these diseases are more common in women. Up to 90% of cases have happened in women. Often they're associated with other autoimmune disorders, particularly type 1 diabetes, but also thyroiditis and vitiligo. In about 5 to 10% of these cases, there's an association with malignancy, including thymomas, lung cancer, and breast cancer. And often you'll have intrathecal synthesis of GAD antibodies. So when you test the GAD antibodies in CSF, they will be positive in those patients that have neurologic manifestations. But those who do not, for example, those who have type 1 diabetes, will not have these antibodies detected in CSF. And finally, there's often positive CSF oligoclonal bands, as these are neuroinflammatory conditions. So we'll start with our first case. This is a 56-year-old male, Tanzanian national, who in late 2021 presented with back pains and stiffness, which then progressed to spasms and stiffness in his legs. And on examination, he had an upper motor neuron syndrome. And the initial doctor in Tanzania thought, is this motor neuron disease? And referred him to us. And when he came in June 2022, his investigations, his MRI brain and spine were normal, and his EMG showed no features of motor neuron disease, but was suggestive of stiff person syndrome. And when we investigated his serum anti-GAD antibodies, then they were negative, and at that point we did not do CSF antibody testing. So based on the EMG findings and the clinical syndrome, we started him on treatment for stiff person syndrome. He was started on IVIG and diazepam. Unfortunately, because of financial constraints and logistical constraints, he was lost to follow-up for about a year until April 2023. And the initial recommendation had been for monthly intravenous immunoglobulin, but because this was proving challenging, we made the decision to treat him with rituximab. And when we saw him early this year, he had improved clinically. Initially, he needed a frame to walk, and by this time in January, he was now using a tripod, and his speech was also better. And when we repeated his investigations, we found that he was positive for anti-GAD in his CSF, and he also had positive CSF oligoclonal bands, which can happen in stiff person syndrome. And his repeat EMG showed improvement in the initial features, which confirmed that the rituximab was working. So this is a video of the same patient. As you can see, he's quite stiff as he walks. These patients are often described as walking like a tin man or like a statue. They're hyperlordotic, and they have difficulties, particularly with bending, because of simultaneous contraction of the abdominal muscles and the paraspinal muscles, and they can also have difficulties with turning back. And this video was actually done post-treatment, and he had actually improved, because when he came in, he really could not ambulate. So the pathology of stiff person syndrome, on the left you have the normal, and on the right you have what is pathological. And usually when you have contraction of an agonist muscle, you have the GABA interneurons, which release inhibitory signals to the antagonist muscles that then relax, which allows for normal movement. But on the right, which is for stiff persons, you have loss of those GABA interneurons, so that when the agonist muscle is contracting, you are not able to relax the antagonist muscle, and the antagonist muscle also contracts, and this causes significant stiffness. Diagnosis of stiff person syndrome: you have the clinical manifestations, so axial rigidity, episodic muscle spasms. There's the characteristic findings on EMG. You have the immunologic studies, of which anti-GAD antibodies in serum and CSF are usually sent, among other antibodies, including anti-glycine receptor, anti-ampifycin receptors. And very important for these patients is to screen for coexisting psychiatric illness, particularly anxiety and phobia. Treatment for these patients, so most of them will respond to symptomatic therapy with baclofen or diazepam, which work because they are GABA agonists. Should work in majority of the patients, but should you find patients who are unable to tolerate this treatment or do not respond well to this treatment, then you can offer them immunomodulatory treatments, usually IVIG, and second line you can also offer rituximab or other immunosuppressants such as azathioprine or cyclophosphamide. Moving on to the second case, this is a 60-year-old female who had a history of rheumatoid arthritis, for which she had been treated with methotrexate but had been off treatment for about 10 years. And in 2020, she came in with gradual onset balance issues with recurrent falls and slurred speech, and initially had been diagnosed as Parkinson's and put on Sinemet, but she did not improve. So when she came in for a second opinion, her examination showed that she was ataxic, she had dysmetria, and her MRI brain that I will show on the next slide showed that she had cerebellar atrophy. Her antibody panel was positive for anti-GAD65. She had a CT chest and abdomen that was negative for malignancy, and she was started on high-dose steroids, eventually switched to mycophenolate, and has been on that ever since. And we've been monitoring her treatment over time with the SARA score, which has improved from a SARA score of 6 to a current score of 0, and she's currently functioning independently. This is her MRI. Unfortunately, the pointer is not working, but I can just show you here that the cerebellum is atrophic. There's loss of bulk in the cerebellum, and in these spaces, you can see that there's an increase in the interfolial spaces in keeping with cerebellar atrophy. This is a video of the same patient. This is a video of the same patient. You can see she's walking. This is her post-treatment, and her gait is still broad-based. And as she turns, you can see that she's still quite unsteady. However, she's able to function independently, and it's quite a significant improvement from how she was when she initially came in. I try it. Is this one right? No, not yet. It's okay. It's okay. I have some, but it's fine. I can just continue. Okay. Okay, it's okay. It's okay. Thank you. So, and when evaluating patients who come in with ataxia, some of the questions you need to ask yourself: if this is a young patient or an old patient? If they are young, then it's likely to be a genetic ataxia. If they are older, and then you need to look at the progression of this illness. Is it fast or slow? If it's fast, then you need to urgently screen them for paraneoplastic causes. So you need to send off your paraneoplastic antibodies, you need to do a CT scan or a PET for these patients. Any patient who comes in with ataxia should have certain tests at baseline, including thyroid function, B12, folate, and then imaging. On this imaging, should you find a structural abnormality, then you manage that appropriately. Should you find just cerebellar atrophy, then it's important to look for autoimmune causes or other causes of cerebellar ataxia, and that's the point at which you would send off your anti-GAD antibodies. And and in terms of management of cerebellar ataxia, particularly autoimmune cerebellar ataxia, immunosuppressive therapy is important because without that, then invariably they progress. And first-line treatments include high-dose steroids and rituximab, and often they will require to be on some form of maintenance therapy with mycophenolate, as we did in our patient, or azathioprine. This is the STARA score. So the areas highlighted in blue are just, so this is a scale that we use to objectively assess patients who come in with ataxia. And this is the usual bedside examination that we do. So you're looking at their gait, their stance, their sitting, you look at their speech, their finger-nose test, rapid alternating hand movements, and heel shake, and you're able to objectively quantify the level of disability that your patient has. On to our third and final case. This is a 36-year-old female who came presented with seizures in 2012, which we will be describing on the next slide. And these seizures were often catamenial and nocturnal, and she had had a trial of multiple anticonvulsants of the years, to which she remained refractory and continued to get multiple seizures. In 2013, she had had a history of type 1 diabetes, and initially she had presented in DKA. And in 2018, we tested for serum and CSF anti-GAD antibodies, which were positive, but at the time it was unclear the clinical significance. And her initial MRI brain was actually normal, but in 2021 she had developed a new hippocampal sclerosis, and she was eventually referred for epilepsy surgery in 2022. So this is her giving a description of her seizures via a teleconsultation. So this patient had temporal lobe epilepsy, which can present with unique auras. Often patients report a rising epigastric sensation. Sometimes they can have olfactory auras, so they smell something. And sometimes they can also have psychic auras, like she did. And this is another video of the same patient getting a generalized tonic-clonic seizure, and this was towards the end of the seizure, so there was tonic-clonic slowing down, but you can see that she is unresponsive, and as she turns, you can see that she had also been frothing. Okay. So these are her scans. These are coronal flare scans, and on the left is before the surgery, and on the right is after surgery. And on the left, in this area, you can see that she had hippocampal sclerosis and atrophy, and post-surgery, she'd had anterior medial temporal lobe bectomy done. You can see that area is now missing. So unfortunately for her, she had, after 6 months post-surgery, the seizures recurred. And the decision then was made to treat this as an autoimmune epilepsy and to treat as an anti-GAD-mediated epilepsy. And she was pulsed with steroids, received IVIG, and is currently on maintenance rituximab. And her seizures have dramatically improved after these immunomodulatory treatments. And some of the lessons to think of from this case are to consider autoimmune causes in medically refractory epilepsy, and to consider the fact that epilepsy surgery, we need it for our patients, and it's a significant gap. Patients have to go overseas, many cannot afford, and despite the fact that she got epilepsy surgery, it's not always curative, as we saw. So in summary, anti-GAD65 mediated syndromes are diverse. We do see them in our part of the world. We should have a low threshold to look out for such conditions. So should you get someone in whom you're thinking motor neuron disease, you should look for anti-GAD. If you have someone with a new onset ataxia in an adult, or a medically refractory epilepsy with normal scans. And recognition allows timely and appropriate treatment, which improves patients' lives. Thank you. I'd like to acknowledge Prof. Soki, who shared his cases with me, and Dr. Sylvia Mbugua, both of whom supervised this presentation. Thank you.
So I would request all the presenters to come up on stage, and also the father of neurology, Prof. Joey. Prof, you have to come up on stage, please. We cannot have a Q&A without Prof there. One more? Yes, one. So we can start by taking a few questions.
First of all, thank you. It's been awesome just listening to the cases that you've presented, and I can see that Dr. Silva and Prof. Soki are mentoring you very well. I really found it interesting. The question is for Dr. Zian. For these patients with IIH, what's the relation with PCOS patients? I see quite a number of patients rapidly growing weight. In fact, one of the things you've noticed with your cases was they were having a really difficult time trying to lose weight, and those are the problems that we experience in our endocrinology clinic. So I want to know if there's any relation between your PCOS and IIH and the role that hormones play. You mentioned about the role of the GLP-1 analogs, and you'll be hearing more about it in KDSG. But one of the problems we've experienced, especially with using semaglutide, we don't have tirzepatide just yet because of cost, is that they're very good in achieving weight loss, up to 20 to 30%. The problem is when you stop, you just bounce back immediately. And then number two, cost is quite prohibitive. So it would be good to know how you follow up these patients. And then to Dr. Linda, my worry, you had excellent patients. I mean, it's amazing. Thank you for sharing the cases and the videos. I'm just wondering, for all the physicians who are here in the audience who have been treating Parkinson's, and we've been saying they're not getting better, so we start with levodopa, carbidopa, and we just keep on giving other drugs. I don't know, is there a way, some are not able to afford to do some of the tests that you have mentioned. So I'm wondering what threshold we should reach at which then we can refer then the cases to you so that we know, because I think there's a lot of mismanagement where we're concerned. And a final question, which famous musician has stiff person syndrome?
Thank you very much, Dr. Sylvia and team, for those excellent presentations. I have 3 questions to the team. Is there a retrospective study that would show probably that several missed out cases are turned blind? Are we able to do that? How long do we give the anticoagulation for CVST? And I have seen a lot of radiological diagnosis of IIH based on increased optic nerve tortuosity. Is that correct? Thank you.
2 questions. One, there is that retrospective study on thrombophilia, on CVST. My question is it likely that in the Aga Khan Hospital, they do thrombophilia screening for all cases of CVST? I think that is important because it's a very expensive test. We cannot afford it all the time. Then the other question is to, I think the last presenter, Linda. This is about the statement you made, I don't know, and maybe I got it wrong, that the anti-GAD antibody levels are quite high in neurological conditions, but they are quite low in diabetes. I need to be educated on this because I know it's the other way around, that it's also high in diabetes.
Hello, I'm Dr. Patil. I would like to ask if there is any role of serial lumbar punctures in IIH, and if there is any role of steroids, because I have seen some neurosurgeons giving steroids in IIH. Thank you.
Okay, thanks for the questions. I'll try to answer them sequentially, but I'll ask for help if I get stuck. The first question was about polycystic ovarian syndrome. In some studies, there's actually been an association between PCOS and IIH. The question that always comes up with IIH, what leads to the other? Because, for example, conditions like PCOS, obstructive sleep apnea, have been associated with IIH. The problem is there's no study that has shown the IIH is from the PCOS or the OSA, but not from the weight gain itself. So the main driver of the underlying pathology is the weight gain. The truth is, patients with PCOS are at increased risks. But in the study that we did, we only found, I think, 4 patients that had PCOS. But that does not allude to the fact that we diagnosed PCOS in all patients. Probably, we missed PCOS in our patients. Secondly, and I'll try to answer that with the lumbar puncture question. Weight loss has been shown to be quite effective and quite rapidly to reduce the CSF pressures quite rapidly. The problem is, even with the best medical treatment, we saw the visual acuity, once it's gone, it's actually gone. So you want something that acts quickly. You're right, even with semaglutide, even with bariatric surgery actually, they will lose weight, and some studies have actually shown some of these modalities can lead to even 30-35% weight loss, but the weight tends to come back. The unfortunate bit with IIH is once the weight comes back, everything comes back. And now the question becomes, where do you go? And these are studies that, this is a question that probably I will refer to Dr. Mbugua, advise us on that. Patients who come with fulminant eye symptoms can sometimes have lumbar punctures to ease the pressure. But patients who have immediately sight-threatening symptoms, at least at Aga Khan, we send them early to neurosurgeons to actually put shunts. There is a role for steroids, but as far as I know, there is no study that shows benefit. The problem with steroids is actually these patients are predisposed to have metabolic issues. You put them on steroids, you unmask diabetes, you unmask all these things. So if you're at a center that you can actually get patients to be seen by neurosurgeons, they do shunting, and I think there is a role for optic nerve fenestration that is actually also coming up. The last question was about patients who actually lost their sight. We found 2 patients who had visual acuity of 636, and these patients were actually referred quite early to neurosurgeons, and they were admitted and had shunting procedures, I think within 2 days of presentation, if I remember correctly. But in this study, no patient that was at significant risk for visual loss was put on medical therapy and actually came back with visual loss. What we found is patients did not improve with best medical management. Thank you.
Okay.
Thank you so much for your questions. So in terms of treatment, both the AHA, that's the American, and the European Stroke Organization agree that in the acute phase, that's your 5 to 7 days, you give a low molecular weight heparin, and the patients, the subcategory, you put your unfractionated heparin, like the ones who cannot get the low molecular weight heparin. Then you transition to your oral agents, your oral vitamin K antagonist, and now the DOACs are gaining favor. You'll put your patients on this treatment for 3 to 12 months, and this will be guided by your repeat imaging with resolution of your clot. Exception to the rule are your pregnant patients and the antiphospholipid antibody syndrome. The antiphospholipid antibody syndrome can only be put on warfarin. There's a large study, there's a trial that showed that they don't do well on DOACs. For your pregnant patients, they can only be put on low molecular weight heparin, and you put them on it through the whole of their pregnancy and up to 6 months postpartum. Yeah, and those are the treatment guidelines. As for the question on screening, we did have a significant number of patients who had thrombophilia screening in our setting. The commonest test was protein C and S, of up to 83% in our setting. I understand this is not replicable in the whole country. Like I said, we are tertiary, we're a private institution, most of our patients have insurance, but at least for your high-risk patients, you can do a protein S. You don't have to do the whole panel of there are about 6 to 7 tests. You don't have to do the whole panel. Our study showed the commonest was protein S. So the least you can do, high-risk patient, send a protein S. Yeah.
Thank you for the questions. I'll start with the easiest one about which famous personality has stiff person syndrome. So that's Celine Dion. She came out publicly about her diagnosis, I think sometime last year. And then on to the second question about at what point should the physician refer these patients. I think when it comes down to it in neurology, what's very important is localization, so your physical examination. So what would make you think this is Parkinson's versus, say, stiff person syndrome? And usually there's a clinical criteria before you need any imaging or any specialized tests. So for example, for Parkinson's at the bedside, you need to demonstrate bradykinesia, you need to demonstrate rigidity, you can look for autonomic instability, and finally the resting tremor. And then for stiff person syndrome, they have rigidity, and this rigidity is often in the axial muscles. So you'll find assessment of their gait is particularly important. Their gait will be hyperlordotic, like it was in that patient. So it's like they're bending forward, they're unable to bend down. Then their history will be significant for muscle spasms, which is lacking on the side of Parkinson's. And then now you move to the more specialized tests like EMG and the autoantibodies, which are difficult to check for out there. But I think your bedside examination will be useful in leading you one way versus another way. And ultimately, should your patient be on treatment and not be improving, I think that's a sign that you need to send them to someone else, send them to a neurologist. Neurologists are few, but I think with the fellowship program will be more and more and should be more accessible out there. And then finally, to the last question about the GAD65 antibodies. So the most commonly method of testing for GAD65 antibodies is ELISA, and the cutoff that we use to say high versus low. So high is more than 10,000 units, and usually 10,000 units and above is more common in patients who have neurologic syndromes. Patients who have type 1 diabetes will have positive anti-GAD antibodies, but they will not be as high as 10,000 units. So should you test and find more than 10,000 units, then it's probably a red flag that there could be. And of course, you'll also tie in your clinical presentation, but it could be a sign that there is an underlying neurologic syndrome as well. Thank you.
Okay, thank you to all the presenters. So I'll just make a few comments. They've done very well. So there's one doctor in the audience who asked about steroids. Steroids are actually not being found to be beneficial. In fact, they can actually be a cause of IIH. And that's why even the PUCOS that Rosalind talked about actually comes in. So steroids should not be used. Other drugs, oral contraceptive therapy, some antibiotics like linezolid. So you should always strive to try and find a cause for the IIH. Other etiology for IIH are things like cerebrovenous sinus thrombosis, malignancies. All those will contribute to IIH because they actually interfere with reabsorption of the CSF into the venous circulation. So you find a buildup of the CSF in the spaces, and that's how the patient ends up with IIH. Another cause of IIH are things like subarachnoid hemorrhage and also the subdural hematoma. So think about this in your elderly patients. So steroids should not be used. Treatment, let me demystify. MRI remains the benefit of very, very few institutions in this country. All you need is to take a good history. Most patients will present with headache. They will have blurring of vision. And I think we all need to know how to do an eye exam because you're the first line of defense. They tend to have what we call tunnel vision. Ask the patient, very small things. Prof taught us and he will tell you, if in neurology you do not get your answer from the history and examination, go back. No form of investigation will help you. It will just add to what you're looking for. You're like an investigator. So ask them, when they're driving, do they keep on hitting the boda bodas? You know the way nowadays they drive past your car. Do you bang things on the side? They do not tend to see, they have peripheral visual blackout, so they only see stuff in the middle. And then do an eye exam, you'll find they have papilloedema, they have loss of the venous pulsations. When you do an eye exam, you'll actually find the confluence of the vessel is broken. And if a patient has that, all you need is a basic CTV, rule out anything that can be a contraindication to a lumbar puncture. Do your lumbar puncture. What we need to access are manometers. These are very, very important tools. We need to get them for most of our hospitals. If the CSF opening pressure is raised above 24 centimeters of water, that tells you this patient has IIH. So history, eye exam, CT, and a lumbar puncture. That clinches the diagnosis for you. You can actually send the patients to an ophthalmologist because you need to have a baseline where you're starting from. And then they need to have their eye exam every 3 to 6 months. Treatment, as Zian said, is acetazolamide. It's a carbonic anhydrase inhibitor. It actually tries to increase the clearance of the CSF. Topiramate works the same way, but caution, topiramate can give you a maculopathy. That's why they need to see an eye specialist, and you might need to just put them on acetazolamide. Both drugs are actually contraindicated in pregnancy. They can cause teratogenicity, and patients will come to you that they have paresthesia in their hands. It's not a new disease, that's a side effect of the medication. So encourage them and tell them to continue. They need to be on treatment until the symptoms settle down, and weight loss needs to be a sustainable, they have to be on a strategy that works. As Rosie said, the GLP drugs are very expensive and they're not sustainable. So let them work with a nutritionist, let them start on an exercise plan. Actually, weight loss is a prescription, number 1 prescription in IIH. So I hope that clears that up. And then thrombophilia screening for all patients with CVST. If you can identify an etiology, for instance, pregnancy is one of the causes, dehydration, infections, especially otitis media with collections, patients who have infections of the teeth, eyes, all those will give you a CVST. Trauma, if you can identify a cause, you don't need to do a thrombophilia screening. But if it's a young lady, you can see they probably have connective tissue disease, they have the facial erythema, they have hypersensitivity, photophobia, they have oral sores, go ahead and do a thrombophilia screen. And point of note is that you need to do a thrombophilia screen before you start them on anticoagulation. Otherwise, don't do it because it will give you a false negative result. So do the thrombophilia screen first and then start them on treatment. We need to work with our labs because these are essential lab tests. They are no longer just a luxury. They are so important because if you find a patient with a thrombophilia abnormality, that's probably a patient who needs to be on lifelong treatment. That's the difference that it makes. But if there's a cause, a CVST, pregnancy, treat for 6 months. We actually, Prof will probably agree with me, treat for 6 months to be on the safe side, and then repeat a scan to make sure that you actually have recanalization of your venous sinuses, and then maybe now you can taper off. There are patients who might need to be on treatment for a longer period of time if you find that they're not getting recanalization. And then there are patients, we've had a patient we've treated for 2 years, and what happens that you still keep on seeing the same thrombosis? What happens that you get a calcification? So it's no longer an active venous sinus thrombosis, it's actually a calcification. I think that's most of what was said, yeah.
Okay. They have said everything, actually. I don't know what to say. I'll just make some comments, because I'll just comment through all the 3 presentations. Cerebrovenous sinus thrombosis actually is not rare. We don't look for it. You see, a lot of times patients come, and the fact that they're ladies, you know, I know today is Women's Day. The fact that they're ladies have a headache, then they start saying, oh, what's your social background? And everything is taken to stress, whatever stress means. So a lot of patients come late when they have had all manner of, 5 MRIs, they've got CT scans, and then they are given anxiolytics, antidepressants, but nobody gets into the line, could we be dealing with a CVST, right? So that's why they come late. And most of them I've seen patients who have had headache for several years, 5, 6, 7, even 10 years. You get them, you diagnose them, you start them on treatment, and within 2 weeks, it's like, okay, I don't have a head, they touch their head. There's no headache in this head. So that's the problem. One of the things in the small kind of collections we have, headaches is the major presentations. And okay, the ones I see don't come with stroke as such. They just come with headaches. And most of the MRVs we have done are more of the left transverse sinus. If you read literature, they talk about a majority in the, there was actually a recent article, I think, was it 3 days ago? They talk about the anterior part of the sagittal sinus, but the ones we see mainly, at least in the registries I have, are left transverse sinus. If you look at the left transverse, if you look at the transverse sinus, you'll find that they are not the same size. You'll find one is always bigger, and usually the right transverse sinus is usually bigger than the left transverse sinus. And that probably might explain why most of them, the transverse sinus is usually not uniform. That might explain why it's common in the left. The other thing is thrombophilic screening. I do it a lot, but I do it a lot because the patients who come are at the end of the road. A lot has been done. So you start almost instinctively think, am I dealing with CFHT? And again, like you say, protein S, low protein S activity is much more. I used to do factor V laden, but I've stopped doing it. So it's mainly protein S activity. Interestingly, I'm seeing a lot of patients with sickle cell trait. I don't know whether because I'm in Kisumu, but patients, one of the things you should think about when a patient comes with CVST is to do HB electrophoresis. There's a sizable number who are carriers, not necessarily sickle cell disease carriers. So I think that's an important point. The other important point is most of the patients I see do not present with hemorrhage. Therefore, they don't really come as stroke. But there's one thing, Sylvia is right, 6 months. There's one thing about anticoagulation. A lot of patients get into hemorrhagic complications because of anticoagulation. And I don't know, you young guys should do some study. I found that if you use the recommended dosages of anticoagulants, they tend to develop, the patients who have actually died because they were given the appropriate anticoagulation and they've died of hemorrhage. So there's something about how we handle anticoagulants. So I have a tendency of using a lower dose, and actually they do fairly well. The other thing is one of the other histories I've found, and I've also seen it in literature, it's a thrombosis. So historically, you may find that the lady has had first trimester loss, pregnancy loss. Very interesting. And usually you go further and say, has your sister or your female relative lost pregnancy? Why are you asking? No, just answer the question. Yeah, my elder sister lost a pregnancy. I've lost 3 pregnancies, and they turn out. So this thrombophilia thing probably even go back to the placental issue. So it's important. When you see them, try to go into that angle as well. Then there are several things that can cause raised intracranial pressure, right? A lot of secondary causes. So when you come to idiopathic intracranial hypertension, you have eliminated all the causes that can cause raised intracranial pressure. Now this is a small group, and this is the group that we're talking about. There are, of course, the etiology is, that's what they call it, idiopathic. We are so idiotic, we don't know what's causing it. But you will find that there are certain aspects, the weight and so on and so forth. One of the other things is, some of the theories is, there's an inflammatory component, and that is why probably some people use steroids. If you read the literature, although steroids should not be used, if you read the literature, there are patients who are found to have relatively high cytokines. And what this does to the choroid plexus, it increases the CSF pressures in the choroid plexus, CSF volume. It's also thought that vitamin A, because if you read literature, some people will tell you avoid vitamin A, whatever. I don't know how you can avoid vitamin A. But it is thought that vitamin A probably also increases the aquaporins within the choroid plexus and therefore increases the CSF pressures. He rightfully said that there are patients who come and you've done everything. You've actually even done repeat lumbar punctures. They see Sylvia and they see that lumbar puncture posture. So now surgeons come in and do fenestrations. For some reason, surgeons are very, I don't want to say scared, but they will not do it. But that's the ultimate, is right, or a shunt. Because you do repeat lumbar punctures and they keep on going on. And I've seen a few patients who have IIH by definition, not just raised intracranial pressure. You've gone through all that. And they're not very obese, they're actually slim. So there's like a small group where they are slim, but they have raised intracranial pressure. So the management can be very difficult. Then the other thing was anti-GAD. There's a cohort I have, and like rightfully they say, they present with seizures, and if you do an MRI, they almost invariably have some limbic white matter changes. So there's like a chronic limbic encephalitis kind of picture, if you will. And a lot of them present with non-convulsive seizures. Most of the times they're non-convulsive. And that's what the patient was describing. Déjà vu, jamais vu. They have got these gustatory seizures, which is an indication of a lesion within the uncus, part of the temporal lobe. So they have these butterflies in the stomach. They have this feeling of they want to vomit. And all of a sudden in this room, you're smelling potatoes being roasted. And in Eldoret, they don't eat roasted sweet potatoes. So where is this coming from? Those are the hallucinatory smells, the anosmic hallucinations. The patients are presented also with what looks like a mononeuritis multiplex. There are multiple nerves involved. Doesn't seem to be glove and stocking pattern. They are not a radiculopathy. So you have a patient who has a neuropathy in the right hand, one in the right leg, and they're not diabetic. They are not having high cholesterol and stuff like that. So you start thinking of, am I having anti-GAD? We have had patients who have come, and again, when you read literature, you find them. We had a lady who came and primary infertility. I don't even know why I did anti-GAD, but there are several people in that group. So what I'm saying, if you see a patient who doesn't seem to fit in systems and they're seriously unwell, it is good enough, like she said, have a very high index of suspicion of anti-GAD disease. They come with myelitis, they come with psychosis, just like she mentioned, and a lot of elderly patients coming with what looks like SCAR, spinocerebellar ataxia, just like she mentioned. And you don't get a typical family history and stuff like that. And you also have those who have myelitis with spastic paraparesis. So I think in summary, it's a high index of suspicion, both for cerebrovenous sinus thrombosis and anti-GAD disease, but they are there. We don't see a lot of stiff person, the typical stiff person. I only had one lady who had this typical stiff person syndrome. This lady was in Pangani Girls when I was at Aga Khan. That's around 2008. She would come to the clinic and she wouldn't lie down. You would be taking a history while she's standing, right? And she had to be, I don't know how she lies down at home, she had to be lifted to put on the couch. Turned out to be anti-GAD positive and actually did very well. So these are seemingly scattered cases, but what I'm stressing is have a very high index of suspicion to get the right diagnosis. Thank you. Time is up. My microphone has been switched off.
I think that's a fitting way to end this session when the father of neurology has the final word, don't you think? And just FYI, how many actually used his pocket book for neurology? Because I personally passed my exams thanks to his pocket book. So, Prof, we need volume 2 and 3 coming soon. And then I'd advise Dr. Sylvia with her team here, I think you should publish these cases. Give us, because honestly, some of the cases we've seen are amazing. Photo, look there. Also, I've been very lenient with you with time. Huh? Guess I'm getting tired. But don't you think it was worth it? I think, please give them another round of applause. For those who've managed to hang on till the very end, I think this was amazing, having the neurology team. And I have to say, one of the things that has been amazing about this particular conference is all the groups, whether it is gastroendocrinology, nephrology, neurology, you've come out in numbers. It's amazing. So thank you for taking time out of your busy practices. Now, we are running rather short of time, so we've had to cancel the team building. In fact, our chair was very upset, Dr. Matthew Coet, so he went running on our behalf, yes, to do the 10 kilometers as promised. So what we're going to do is you can stop by the booths and have a quick cup of tea, and then go and shower and change and come with your glad rags for the gala dinner. We officially start at 7 p.m. Please don't be late so that we don't keep you up too late. And remember, we still have a program tomorrow, even more exciting, but we really want to recognize us, the outgoing officials, and the incoming president and his team. So please don't miss out on the gala dinner this evening. It's going to be again at Lyons Primary School, which is 5 minutes from here, but we'll provide transport. Now, as you walk out, please see Judy, our administrator, to pick up your CPD points, because I understand not everyone registered with their email address, so it's easier for you if you can upload onto your CPD portals. Thank you all so much, and see you at the gala dinner. Have a good evening.